Good morning to all of you, and welcome to this special medical grand rounds in collaboration with the second annual Access to Transplantation Symposium. Our transplant program has a very long history of excellence from 1972, when Dr. Samuel Kountz and Dr. Eli Friedman put the program together. And since then, we've performed more than 3,500 transplants. It's one of the oldest kidney transplant programs in the country. We have the pleasure of having, one of the longest running transplant symposia in the country, started by Dr. Markel in 1998. I joined in 2000, and we ran the symposium until 2011. Then we changed the theme to kidney donation and ran another series of transplant symposia till just before the COVID. Then we had one Access to Transplantation Symposium just 1 year before the COVID. Then COVID hit, then we sort of stopped the symposia. So this is the second Access to Transplantation Symposium by the transplant program after we restarted the transplant program. And we are so lucky to have Dr. Caroline Rochon lead the transplant program since we reinitiated the transplant program about 2 years ago. And we've been doing a lot of transplants. It's just a joy to have a program in Brooklyn. Anyway, so we decided that, to kick off the second transplant Access to Transplantation Symposium, the right mechanism was to join it with internal medicine so that we can have all the information and get a topic that is very close to internal medicine so that we can take some home points and be part of the transplant program. So it's my pleasure to introduce Dr. Caroline Rochon to introduce the speaker for this morning's Grand Rounds. Dr. Rochon, you all know her already. I don't need to mention her elaborate CV, but she's the Chief of Transplant Services and Director of the Transplant Program at SUNY Downstate. Please join me in welcoming Dr. Caroline Rochon.
Good morning. Thank you so much for your interest in transplantation and our program. We're so lucky to be able to talk to you about what helps us get up in the morning and what benefits our patients. So it's really my pleasure to introduce Dr. Segev, who I'm so happy accepted our invitation to come here today. Dr. Segev is a professor of surgery and population health, and he's the vice chair of surgery at the NYU Grossman School of Medicine. He's also the NYU Langone Health, and he is also the founding director of the NYU Center for Surgical and Transplant Applied Research, and which is doing tremendous work here in our field in our city. Dr. Segev was the first to demonstrate the survival benefit of incompatible kidney transplantation across the United States and is responsible for the first HIV to HIV transplant in the United States back when he was at Johns Hopkins. He was also the first to demonstrate poor immunogenated COVID vaccine in those breast patients, which has been so important for our field. And for this work, he received a letter of recommendation from Dr. Fauci. His NIH-funded research includes kidney exchange, desensitization, long-term donor risks, access to transplantation, expanding transplantation, including HIV-positive donors, racial and geographic disparities, which we care so much about here in Brooklyn and at Downstate, post-transplant outcomes, COVID vaccine, and the intersection between transplantation, gerontology, and cognitive decline, which we had the pleasure to discuss with him last night. He has an undergraduate degree in computer science and graduate degree in biostatistics, and that has led a lot of his focus on novel statistics and mathematical method for simulation of medical data analysis and to the benefit of all of healthcare. A lot of surgical residents, it seems, and transplant surgeons know him as the Winter Symposium DJ in transplantation, but Dr. Segev has also published over 900 peer-reviewed research articles, and he's ranked #1 worldwide in the organ transplant expertise and influence by Expertscape. With that, I thank you for being here, and I welcome Dr. Segev to the podium.
Good morning. Thank you for the opportunity to share some stories with you and to take the 5 train. more south than I usually do. So today I'm going to tell you some stories about work that we did on Capitol Hill. Hopefully stories that have a generalizable message of how we can take things from, let's see, does this mouse work? No, though I have to use this. We can take things from the clinic. Ooh, look at that. Take things from the clinic to the research lab, to the media, to the Hill, and then back to our patients. And so I've done a lot of work at local level, state level, transplant community level policy, but I'm going to tell you two stories of things that we did at the national level in congressional policy. Just so you understand sort of how transplant is governed, the congressional level law that governs what we do is called the National Organ Transplant Act, or NOTA. And that was written in the mid-'80s. It's congressional, meaning if you want to change anything in NOTA, you have to go to the congressional level. Below Congress is HHS, and we have our HHS policy is called the Final Rule, the Organ Transplantation Final Rule. And so that's the lower level of transplant policy. And then under HHS is the Organ Procurement and Transplantation Network, the OPTN, now run by a group in Richmond, Virginia called UNOS. So some people use UNOS and OPTN interchangeably, but they're not. And OPTN makes a lot of the policies that we follow. So we have three levels of government policy making. But remember, I told you the National Organ Transplant Act is congressional, and so I'm going to tell you two stories of how we changed congressional law. And when you think about changing congressional law, this is sort of an important statistic to remember, that every year more than 7,000 bills are presented before Congress, and just a handful of them become law. And so getting something across all of that requires kind of an organized, novel, and creative way of thinking about what we do as patient providers, right? Like, this is, I'm a transplant surgeon. I'm not a lobbyist or a political scientist or anything like that, but how can I think about what impacts my patients and take that to the congressional level? I'll start with my acknowledgments first. This is our research team, now half at NYU and half still back at Hopkins. I came to New York about 2.5 years ago. And there's a lot of trainees there as well. And so for those of you who are trainees, remember that the work of trainees is really what drives a lot of this stuff. And the bills that I'll tell you about had a lot of trainee involvement, to the point where one of my trainees, right before he started medical school, got to go to the White House when Obama signed one of the laws that we wrote. And so the pathway I'll talk about today is getting inspired by the clinical work that we do. That's me operating, but I'll assure you I don't usually lean so far forward, but the photographer made us do that so we would get in the picture. To the research lab, to the media, which is how to get the attention of lawmakers, to Capitol Hill. And those of you familiar with I'm Just a Bill, it's basically I'm Just a Bill gives you the formula for how to do this, but it's a little more complicated than that. The first bill I'll tell you about was called the Norwood Act, named for Charlie Norwood, who was a lung transplant recipient and part of Congress. So what inspired us to write the Norwood Act? What was impacting our patients that we wanted changed nationally? And that was the fact that we have a lot of incompatibility in transplantation in this country. And so how many people, just out of curiosity, know what a kidney exchange is? A handful that work in transplantation. About 20 years ago, nobody really knew what a kidney exchange was because it was illegal. A kidney exchange, imagine that you have a living donor, but they're the wrong blood type, or you have anti-HLA antibodies against your living donor and there's a positive cross-match or something like that. The concept of a kidney exchange is, well, maybe this person can give to that person, and this person can give to that person, and so we can make two compatible transplants result from two incompatible situations that would not have led to transplantation. And we got the idea that we really could help a lot of people by doing this across the country, but there was this National Organ Transplant Act that I told you about, which said that it was unlawful to transfer any human organ for valuable consideration. And this is the way lawyers say you can't buy and sell organs. And I wish lawyers would have just said you can't buy and sell organs, but instead they used this phrasing. And when we asked the Department of Justice, hey, what do you think of kidney exchanges? Do you think that these things violate NOTA? After a couple months, we got a little short letter back that said, maybe. That's not something you want to hear when you're considering doing something like that to patients. So there we are, getting inspired by something we think will help our patients, and now we need to do the work to convince Congress to change NOTA to allow kidney exchanges. So interestingly, when I was at Hopkins, one of the things I did as junior faculty was to do a congressional fellowship because I was interested in changing policy, and we were able to do it part-time so I could still operate and then spend a lot of days on the Hill interacting with the American Political Science Association and with the people who really run DC, which are the legislative assistants or the LAs, the staffers down there. And I helped work in one of the offices and helped work on some of the bills that were going on at that time. Maybe a small bill you might have heard of called the Affordable Care Act. And so I learned a lot about sort of how to get Congress's attention and how to get Congress to do things. And a smart health LA at any congressional office will ask you 3 questions when you say you have a health-related thing. One is, how many people are we talking about? 2, what will be the benefit if we do this? And 3, what is the political risk? Okay, so by benefit if we do this, we mean how many lives will be saved and how much money will it cost or will it save? Because every bill that you propose gets a Congressional Budget Office score. And if the CBO score is not encouraging, that means that it's going to cost a lot of money and not save a lot of money, and that those bills with bad CBO scores are very, very hard to get across the finish line. Fortunately, in transplantation, does anyone know how much it costs Medicare every time we do a kidney transplant? It's about negative $500,000. Why is that? Because Medicare has to pay for dialysis, and transplantation is way cheaper than dialysis. So our CBO scores were amazing because every transplant we do, we actually save Medicare money. But it's really important to know that anything you do policy-wise is going to be looked at from a cost-benefit perspective as well. And then when we say what is the political risk, remember that politicians are not policy makers. They're not policy scientists. They're people who represent the people who voted for them in their constituency. And so politicians care about, will my constituency benefit? Will my constituency be harmed by this? And part of when we take things nationally is convincing the folks in Kentucky that the folks in New York are not going to steal all of their organs. And we face that a lot because, there's this sort of, oh, well, the big cities are going to steal everything from the small towns. So the thing we did to take this to Congress is we knew we needed to answer these questions, but we didn't have answers for any of these questions. And so we put together a study, which fortunately got published in JAMA. And it was interesting because this was a simulation, a data simulation study. This was basically computer science. This wasn't medical. And when we sent it to JAMA, JAMA wrote us back and said, we usually do not publish papers of this sort at all, but we realize the potential clinical importance of this and the policy importance of this, so we will work with you to get this into the hands of our readership. And what we wanted to answer was, how many incompatible pairs were there in the country? How many people were there kind of sitting around who would have gotten a transplant except their blood type O and their donor is blood type A or something like that, or they're HLA incompatible with their donor? And the problem is that we didn't have a registry of these because a lot of those got kind of dismissed at the kitchen table. They're like, oh, I'm looking for a live donor. Their brother says, I would donate to you. And they're like, oh, you're the wrong blood type, so I guess that's not going to work out. So we didn't have a registry of incompatible pairs. We didn't know how best to match them. And we need to, if we, again, take this to Congress, which represents the entire country, we need to convince them that we have a matching system that will not just favor New York and disfavor Kentucky, but will favor everyone equally. We didn't know how many lives would be saved if we did all of this, and then we would be able to figure out, if we could figure out how many people would benefit from this, we'd be able to figure out how much money Medicare would save as well. So I have a background in computer science. I did a lot of simulation when I was younger. I'm married to somebody who has a foreground in computer science and does a lot of simulation now. And so we took on this collaboration. She had never worked in medicine or transplantation before. We still have a collaboration. We actually co-direct the new center at NYU that we founded a couple of years ago. It seemed like a good collaboration when our first paper that we ever wrote together got into JAMA. So what we did was we used fundamentals of computer science and medical simulation called random draw simulation. And what we did is we modeled people and the family structures around them, and we used data we knew about how HLA gets passed on and how ABO gets passed on and the relationships between donors and recipients across the country, et cetera, to model for patients potential donors that they might have. Now, if you have 0 potential donors, you're not going to benefit from a kidney exchange, so we don't model those, but we model people with maybe 1 potential donor, 2 potential donors, et cetera. And we put them through what's called a Monte Carlo simulation. And again, we do simulated donors that they might have. We do a simulated medical and psychosocial workup, a simulated ABO test, a simulated cross-match, et cetera, drawing on data that we have from all sorts of national sources. In transplantation, we have a national registry, so we really know sort of as much as we possibly can about how these things work in our transplant field. And when we went through this simulation, if somebody ended up with a healthy and ABO and HLA compatible donor, we put them into a bin that we called direct donation. And if they didn't, we checked the other donors for eligibility. And if none of their donors were eligible, we put them in another bin called potentially for kidney exchange or kidney paired donation, which is what we called it. And we ran this simulation until about 6,000 people landed in the direct donation bin. And that's the number of direct donation live donor transplants that were done. And then those that were left over in that other bin were the ones that we could make an assumption about would have undergone a transplant had they found a compatible option. And then we used what's called integer program optimization. And we used that to take all of the incompatible pairs. So it turns out every year there are thousands of incompatible pairs in this country. Thousands of people who come forward, have a living donor who is healthy and willing but is HLA or ABO incompatible. And then how do you take all of those 1,000 and find sort of the best matches for people? And without going into the math of integer programming optimization, I can assure you that there is math that lets us find the optimal number of transplants that does not disadvantage certain geographic areas, that does not disadvantage any racial groups or anything like that, that in an equitable way can optimize the potential of these exchanges across the country. And this was what we needed to take to Congress to promise people that nobody would be disadvantaged by this. And it turns out that we estimated that we would be able to do more than 1,000 transplants every year in this country through kidney exchanges, and that is about 20% of the live donor transplants we do in this country. So that's a huge increase in live donor transplantation that was blocked by the fact that we had this law that said we couldn't exchange for valuable consideration because that's the way that lawyers speak. So then we have this JAMA paper. How many people here think that 23-year-old Princeton grad legislative assistants from Capitol Hill read JAMA? They don't. They read the New York Times, they read Politico, they read actually Congressional Quarterly, CQ, which is like that's their JAMA. So we needed to get media attention for this. We were a little bit fortunate that Time Magazine named us Innovators of the Year for doing this kidney work. And so we got some attention through Time Magazine, but we also then used that to leverage to all of the other publications, all of the other newspapers across the country. And this was an era where we would actually go to the magazine stand and buy 100 copies of Time Magazine and hand them to legislative assistants on the Hill to take back to their offices and read about it. And so once we got the attention of mainstream media, then we went to the Hill. We drafted this bill. I actually drafted all of the words for the original draft of the Charlie Norwood Act. And basically, the key section of the bill said, for the purposes of this section, kidney pair donations. Now, we called them kidney pair donations instead of kidney exchanges because remember, the original law said you couldn't exchange an organ for valuable consideration. So we didn't want that word exchange anywhere near what we were doing. But we said that KPD not considered to involve the transfer of a human organ for valuable consideration, found support, bicameral support, bipartisan support. These are the senators that supported it. These are the folks from the House that supported it. I'll get into, in the next story I tell you, I'll get into a little more detail about what it's like trying to get these folks to sign on to a bill. But ultimately, this bill flew through. Same year it was introduced, it ended up passing through both branches of Congress and went to the president. And this young man, which was me, or younger man, and this other younger man, which was the president at the time, signed the bill into law and made this possible. So then we take this and bring it back to our patients. And that's really, really important to remember, is that if you go through all the effort to change policy, you're only a quarter of the way there. You've got to take it back to your patients, implement the policy. The next story I'll tell you about this becomes really, really critical. And we need to be able to bring this to our patients. So there were a handful of centers kind of doing this rogue before the Norwood Act passed. And you see those are these little numbers before 2006. When the Norwood Act passed, the use of kidney exchange in this country blew up, as the kids would say. And it's because we were able to create a national multi-center kind of clearinghouse for kidney exchanges, and we were able to exchange across the country, allowing somebody in New York who had a very, very rare need for, had a weird anti-HLA profile, had a rare need for somebody, and maybe that donor was only in California, and we needed to be able to connect all of these folks together. And today we do about 1,500 or so kidney exchange transplants per year. And remember, I told you that that's what the simulation estimated we would be able to do with this. So we promised this to Congress and the Congressional Budget Office, and actually it became true. And today, again, now it's closer to 25%, but about 20 to 25% of the live donor transplants that we do in this country come through kidney exchanges. The work that we did impacted work in other countries as well. The Canadian system adopted what we did in the United States, and they do a bunch of exchanges. These are European countries who are in slow levels of adoption of kidney exchange across Europe. There's an Australian kidney exchange program based on the work that we did in the United States. And there's even a kidney exchange program in Ahmedabad, India, that has started to grow that is impacting the rest of that country as well. So not only impact for our own patients here in the United States, but a lot of countries had kind of similar laws that came about in early efforts to prevent organ sales that were blocking them or hindering them from doing kidney exchanges, and this impacted them as well. So that's story one. Taking on Congress to make a change in the National Organ Transplant Act to allow kidney exchanges to happen, and the impact of that. And hopefully you see that the impact of it is quite meaningful to the people that I take care of on a regular basis, and made the tremendous amount of effort that it took to get that passed worthwhile. The second story I'll tell you about is the HOPE Act, or the HIV Organ Policy Equity Act. I'd like to say that I was clever enough to name it the HOPE Act, but it was a 23-year-old Princeton grad working as a health LA in one of the congressional offices that suggested this, and suggested that we introduce the bill on Valentine's Day, which we did, which was adorable. But here's another story of something that was impacting our own patients and how we modified a congressional bill to make this possible. So, what were we seeing? What was I seeing in my clinic, in my operating room that was inspiring me? Well, it turns out that since the 80s, remember that's when NOTA was written, HIV is a very, very different disease. Today, they estimate that if you have HIV, your life expectancy is the same as if you had not had HIV, which is really impressive. It turns out if you have HIV and kidney disease, that's a bad combination. People with HIV on dialysis have half the survival as people with HIV, as people without HIV on dialysis. So it is a bad combination to have HIV and be on dialysis. Well, we'd want to transplant them, right? As transplant surgeons, we want to transplant everybody. And the option that was available to folks was what we call a D-R+. So the donor is HIV negative and the recipient is HIV positive. And in this country, thanks to seminal work that was done out of UCSF by Peter Stock, it was made possible for us to transplant people who were HIV positive, so HIV positive recipients. And kidney transplantation was growing quite well, and liver transplantation was growing quite well also. And based on those data, based on hundreds of transplants that we had done in the United States, we actually discovered, observed, confirmed that if we transplant somebody who's HIV positive, their outcome is actually equivalent to transplanting somebody who's HIV negative. So if they're on dialysis, they do quite poorly, but if we transplant them, they do actually very well, meaning that their survival benefit, the benefit they get from the transplant, is actually more than the benefit that somebody who's HIV negative gets from the transplant. And I'll tell you, I tell that fact very naturally because I told that fact about 500 times in DC when every single person I talked to said, well, why are we even transplanting people with HIV? Don't they just do really poorly? And we actually needed to do the science to show them that actually they benefit more from a transplant than their HIV negative counterparts. Well, what about HIV positive donors? It certainly would make sense that if somebody's HIV positive, they should be able to get a transplant from somebody who's HIV positive. And when I was starting out on faculty, I was greatly inspired by a colleague, Elmi Mueller in South Africa, who had this incredible story. If I had another hour, I would tell you her whole story. It's fascinating, and it involved her almost going to jail, her almost losing her medical license for doing this. She was in a scenario, so in the US, if you have kidney failure, you get dialysis, right? Medicare pays for dialysis. Dialysis is really, ESRD is really like the only, national healthcare system that we actually have. If you're in South Africa and you have kidney failure and you can't pay for dialysis, you die. And a lot of the people she was taking care of were HIV positive, had no means to pay for dialysis, and she was seeing them die. They also have a much higher HIV prevalence in her region than we do in the United States. And as a result, she was seeing a lot of people die as potential donors, and nobody was using their organs for transplantation. There was no law there prohibiting it, but it was kind of like accepted medical practice that you wouldn't do something that insane, like give somebody an organ from somebody who's HIV positive. Well, she said, this is stupid. And she did it. She did it in 4 patients. They all did incredibly well. This got out to the media, this got out to the medical board, et cetera, and they went after her hard. She sent her case report to New England Journal. New England Journal published it, and then all of a sudden, she's the hero of South Africa. So if you're going to do something that might land you in jail, see if you can publish it in New England Journal first. But we were really inspired by the work that she did, and nobody else in the world had ever done an HIV to HIV transplant. And so I wanted to do it in the US, and I found myself up against the beautiful National Organ Transplant Act again, which was written in the mid-'80s when we were in the middle of the AIDS scare. And I will read you the wording from it that said, preventing the acquisition of organs that are infected with the etiologic agent for acquired immune deficiency syndrome. We didn't even call it HIV then. That's how old that congressional bill was. And somebody made the mistake of putting medical practice into a congressional bill. Please don't do that, because then we have to go to Congress when medical practice evolves. And that's exactly what we had to do. And I was like, oh, here we go again. This is going to be another 3 years of my life. And so we go from the clinic to the research lab. And we say, well, what questions do we need to answer? And there were those same questions that we had before. How many people were we talking about? What will be the benefit if we do this? And what is the political risk? So Brian Boyarsky, who was a post-bac, sort of on his way to medical school at the time, had come to my lab and he said, I'm interested in a health policy project. And I said, how would you like to take on Congress? And he said, that sounds fun. And I said, this is exactly the kind of spirit we need taking this on. And so we put together a paper, not in JAMA this time, unfortunately, but we put together a paper trying to estimate how many HIV positive donors there would possibly be out there. Again, this was a scenario where we didn't have the data, because if somebody with HIV is declared brain dead at some outside hospital, they know that they're not allowed to be a donor, so they don't even call the organ procurement organization. And if they do call the OPO is like, we can't use HIV positive donors. Okay, thanks, bye. And that's it, and it's done, and there's nothing recorded about it at all. It's just done. And so we needed to use national data. We used data on a large cohort of HIV positive individuals. We also used death data from across the country to look for people who died in a manner that would have been consistent with organ donation, but happened to be HIV positive, et cetera. And we again estimated how many donors are we talking about, and it turns out that it was quite a few. How many lives would be saved? How much money would Medicare save? And remember, every time we do a transplant, Medicare saves money. So then we took this to the media, and when you're working in the HIV/AIDS space, you get a lot more help than when you're working in the kidney exchange space. There is a very strong lobby in DC for HIV/AIDS care. There's actually a White House HIV/AIDS office that sets priorities for what they do with HIV that year, et cetera. And the year that we were doing this, the White House priority was to destigmatize HIV. And I want you to think about that and how we played that priority when we tried to get our bill passed. So we got the attention of the New York Times. For those of you trying to get your work into the media, the number one thing that you need to remember when taking things to the media is patience. And I mean patients like be patient, but also patients like the people we take care of. So look at the first two words of this article. The first two words of this article are the name of a dude in LA who was willing to be interviewed by the New York Times, talk about the fact that he was living with HIV and that he was waiting for an organ transplant and not doing well, and how this bill might be able to improve his life. And this got on the front page, above the fold, New York Times, and I even got the quotation of the day. So another take-home message is learn how to very succinctly summarize the things that you're trying to get into the media in a few words, because the media likes 10-word little sound bites. And my quote of the day was, "The clock is ticking more quickly for those who are HIV positive." So with this media attention, again, we went to the newsstand and bought 200 copies of the New York Times and passed them out on the Hill. So to get into a little bit more detail for this particular story, we went to Congress, so we talked to people in the Senate and the House. The Obama administration had this national AIDS strategy and the AIDS office, and we talked to them as well. We went to HHS and HRSA about it, and then we had a lot of support from professional groups. In particular, the HIV and AIDS groups had a ton of lobbying power or advocacy power on the Hill. These are all of the groups who gave us their Washington, D.C. advocacy teams to help push this bill forward. The bill was drafted March 2012. The legislative assistants from Boxer and Capps' offices helped us draft the bill. When you write a medical bill, it gets sent to HHS for what they call a technical assistance. It basically is Congress saying, hey, HHS, can you read this to make sure that we're not going to kill people and that this all makes sense? And then we revised the bill and we started the CBO score process. And we worked hand in hand with the CBO to remind them that we save money when we do these things. We got the attention of a lot of legislative assistants. We had a briefing where there was actually a guy who had been transplanted, one of the very first HIV positive recipients in the country, whose job had been a legislative assistant at some point in his life. So he kind of resonated with all of these kids running around Washington, D.C. But the way we really filled the room, we had like 150 people, standing room only, which is crazy for getting a bunch of legislative assistants together. How did we fill the room? We fed them. So the same thing that brings residents out also brings legislative assistants out. This is Congresswoman Lois Capps, who was a former nurse who sort of understood some of the medical issues when we were doing our briefing, and then a few other people that we had speak at this briefing and kind of inspire the LAs to really want to take this forward. Again, bipartisan, bicameral support. These are the main offices. If you get Senate interest in something, the bill is considered more powerful than if the House is driving the bill. So you really want the Senate driving the bill if you possibly can. Again, from both sides of the aisle in the House, it's not that the right side of the aisle there was not supportive of this, but that's kind of what the House looked like at the time that we were bringing this bill forward. When you introduce a bill to Congress, you only have that year for the bill to go all the way through committee, get signed, and get enacted. And if you miss that, then you have to reintroduce that bill the next year. And in transplantation, we've had these frustrations. The Medicare Drug Coverage Act took 10 introductions over 10 years before that bill finally made it across the finish line. So we introduced this on Valentine's Day as recommended by one of the LAs. It went through the Senate committee, came out of the committee quite quickly, and then got unanimously passed on the Senate floor, then was handed to the House, E&C committee, and they just sat on it and sat on it and sat on it. And we were getting really frustrated looking at the date, thinking, well, the last thing we want to do is have to do this all over again next year. So we went to the White House HIV/AIDS office. Remember that office I told you about? whose stated goal it was that year to remove the stigma associated with HIV. And I went to talk to them and I said, look, this is hung up in House committee. Obviously the House, the Congress doesn't really officially talk to the White House, but they all drink together on the Hill, and so they all know each other, and they can really help move things along. And they said, look, that sounds really interesting, but it's not really what our goal is this year. And I said, oh, that's interesting. Who of you here has considered whether you want to be an organ donor or not? And they're all like, yeah, well, of course we considered whether we want to be an organ donor, because we have to decide when we get our driver's license if we're a donor or not. And I said, you have to decide when you get your driver's license if you're a donor or not. Do you know who doesn't have to decide if they're a donor or not? People living with HIV. And they're like, whoa, this is incredible. This is real stigma associated with HIV, is that everybody living with HIV, when they go to get their driver's license, does not get to make that decision. In fact, is told, we don't want your organs, they're worthless. And so all of a sudden, we had some buy-in from the White House AIDS office, and somehow this bill came out of committee, got introduced into the House under suspension, which means look, Senate approved it, so we're going to approve it. We're not going to mess with it. And it got out of the House, and then Obama signed it 9 days later and made that possible. And this is Boyarsky here getting to accompany the team to the White House to watch the bill that he really helped push get signed. And so then we have a bill. We have to take it back to our patients. One of the things that so when HHS reviewed the bill, they said, we're worried that you're going to give everyone in the country HIV. I don't know why they were worried about that, but they said this has to be done only as research, and then the HHS secretary reviews it every year and decides when it's going to become actual clinical practice. And I was like, okay, only as research, I can live with that. Fine, you have to get an IRB if you're going to do HIV to HIV transplants. It's probably good anyway, because then we'll learn, et cetera. But then they said, the HHS and NIH have to come up with the criteria for what is research. And then I had in my mind, okay, so 15 years from now, the NIH is going to create a committee that's going to decide what the rules are, and we're not going to be able to do anything in that time. So we actually put into the bill a 2-year time limit, that this is research, and NIH and HHS have 2 years to publish the research criteria. And guess how long it took them to publish the research criteria? 2 years minus 10 minutes. Literally, they published it the day that it was due to be published, according to this congressional law. So again, remember to build in ways that things get implemented so that they don't just get passed and get stalled. Finally, we were able to do the first HIV to HIV kidney transplant in the United States, and the first one outside of South Africa, and the first HIV to HIV liver transplant in the world, because they weren't doing liver transplants in Elmy Mueller's transplant center. So that was exciting, and we kind of opened the door, and word got around in the HIV community. And, when you work as a transplanter, you feel like you're in this really, really micro niche of medicine. I was getting, because my name was all over the media, I was getting unsolicited emails from people living with HIV across the nation showing me their little driver's licenses and pointing to the little heart that showed that they were organ donors. And this, I forgot how much this impacted, the 1 million+ people in the US living with HIV, which kind of made me forget how much we impact actually as transplanters, the entire community. Everybody knows about transplantation because it's something that everyone is in some way kind of involved in. As a reflection of how he actually keeps up with the things that he's involved in, President Obama found out that we did this first HIV to HIV transplant and sent us a really nice note congratulating us on doing it, and remembering that he had signed the congressional bill that made it possible. In fact, the year he signed the bill, there were only 53 bills that passed into law that entire year. And when you're a president, they give you a bunch of pens for signing bills, because you sign a bill with like 8 different pens and you distribute those to the people who were involved in the bill process. And he said that he had way too many pens, and he was in the Oval Office, he said he's very thankful for our work so he could get rid of 8 more of those pens. Taking this back to our patients, remember it was required to be research. So then we went to the NIH and we said, okay, listen, this is required to be research. Cough up some dough. And we got funding to study the donors and their antiretroviral resistance patterns and things like that, their viremia patterns. We got funding to do a national multi-center study of HIV to HIV kidney transplants and liver transplants, and now we're actually on the year 6 through 10 renewals of both of those. This has been a huge national effort. You're looking at here the kidney centers and liver centers who've participated in this national study. A couple of years ago, we published the first report of HIV to HIV kidney transplants, the largest report that had ever been published, with a comparison group of HIV-positive recipients who got HIV-negative donors. Graft outcomes were spectacular. We published our liver results as well from the pilot study. Now we're getting our liver results looked at by top-tier journals for the final study that we had. And so we were able to start to provide clinical data on what it means to do HIV to HIV transplants. And then the HIVologists are actually very interested in what we're doing, because remember, we're doing this weird thing where we take a donor with some strain pattern of HIV and we take a huge inoculum of that HIV in the form of a liver or a solid organ, and we put it into a recipient who has a different strain pattern of HIV. And there are questions of superinfection, viral dominance, and all of this, particularly given that the recipient is already on antiretrovirals when they receive the transplant, et cetera. We have done a lot of interesting basic science looking at these questions. This is one particular study that we found very interesting, because we looked at 22 recipients who got these transplants, including one who had a breakthrough HIV infection, and we found no detectable viral strains that had come from the donor. So there was no evidence of the donor HIV strain pattern in the recipient. So showing that either the recipient viral strain was dominant, or that because they were on antiretrovirals, there was no further superinfection or anything like that. That was very interesting. We've also done a lot of qualitative work, or more sort of patient-facing work, to understand people living with HIV and their willingness to accept organs from donors who had HIV, their willingness to become donors, as people living with HIV, and the willingness here, you look at like 80% willingness to be a deceased donor, 62% willingness to be a living donor. This is way higher than the general population. In fact, there are special reasons that people living with HIV are drawn to becoming donors, signing their donor cards, et cetera. We did a really interesting sort of ethnographic evaluation of all of this. They feel solidarity with the HIV-positive recipient. They want to reduce the stigma associated with HIV. They want to give back time that they feel is borrowed time. They feel an obligation to science because they're alive, even though a lot of the friends that they had earlier in life died from HIV, and so they're very grateful for that. We've also looked, and we've been able to study, and we continue to study the HIV latent reservoir. For those involved in HIV science, you know that is the one thing keeping us from finding a cure for HIV, is this latent reservoir. And again, we have patients who we can take lymph nodes out of, during the operation, and really study things that would not have been possible to study in anybody else. We also got the idea that the HOPE Act did not specify that the donor had to be a deceased donor. So we made it possible for us to let living donors, people living with HIV, become living donors. And why not? Well, there are a couple reasons why nobody had done this before, even not in South Africa. One is because of HIVAN, HIV-associated nephropathy. But it turns out when we studied this that people on modern antiretrovirals do not have HIVAN if their HIV has been controlled. And the old antiretrovirals were nephrotoxic, but the new ones aren't particularly nephrotoxic. So if you have somebody with very well-controlled HIV who's never had a lot of breakthroughs, who's on modern ART, they have equal kidney function to somebody who is HIV negative, and they have equal risks down the road to somebody who's HIV negative. And we did a whole study on this to identify the phenotype of people living with HIV who could become possible living donors. And then we announced that we're doing this. And within about 4 seconds, I got an email from Nina Martinez, who had been watching all of this because she had acquired HIV as an infant from a blood transfusion. She was an HIV epidemiologist at the CDC and had dreamed her whole life of showing people that HIV in 2020 did not look like the death sentence that it was in 1980. But in fact, HIV in 2020 was a marathon runner who was healthy enough to actually donate their kidney to somebody else who needed a kidney transplant. And so we went through a lot of discussions with her about what this means and what we know about the risks and what we don't know about the risks. Like, look, you're the first person in the world who has done this. We have no idea what's going to happen. She was gung-ho because she really understood all of the science behind it, and she became the first person in the world to donate a kidney living with HIV. If you want more details about that aspect of things, I was fortunate enough to give a TEDx talk on this. You can find this on the interwebs and spend 20 minutes learning a lot more detail about the bill and sort of the whole process of bringing it back to this first. So, stepping back a little bit, what can we learn as medical care providers, not people who work on Capitol Hill, to impact policy around us? Well, learn the policies that are impacting your patients and think from the trenches. Think from what you do as a clinician. Let that inspire you. And then learn the science of how to do the kind of science that impacts policy. Learn how people think who are policymakers and publish for the policymakers. I didn't care if any patients read the study that we did about kidney exchange. I wanted policymakers to read the study we did about kidney exchange. Make connections in the media. I can tell you that all the connections I made through the HOPE Act, when COVID hit and we had a couple of JAMA papers showing that our transplant patients were benefiting from the vaccines, but they were in a sea of a million other COVID factoids that were out there, I just called all my friends who I knew from all of those articles that covered the HIV to HIV transplants, and I said, hey, I got another thing for you. So make friends in the media, learn how to talk to the media, learn how to express your science in 10-word sound bites, and then learn how, whatever level of government you want to impact, learn how that works. If you have time, do a fellowship or just go visit an office. If you're looking at state government, go visit a state policy office and learn how they work, learn how advocacy groups work with advocacy groups and societies and legislative assistants to help move these things along. But don't forget that once you get that thing changed, work it equally hard, if not harder, to bring it back to the trenches so that you can actually impact the patients that inspired you to do this from the beginning. So I'm going to leave you with one last thought, which is that as people in healthcare, a lot of things should piss you off, and if you can, pick one and fix it. Thanks.
All right. I don't know what to say. I have no questions. It's just phenomenal, and so thank you so much. You know, this is just lifetime achievement. If I had it, I would just give it to you right now, but I don't have it. So anyway, let's open it up to questions.
Dr. Segev, thank you so much for accepting our invitation and giving this amazing talk. It really is inspiring and impactful. I often tell residents that the one thing that made me really taught me how to be a surgeon is when I was a figure skater, because I was terrible at it, and it taught me to follow my butt and get back up. And I think now as a surgical educator, if I look at the impact of your career, I think that surgical residency really doesn't prepare one to step on this podium and make this talk. And so what do you think we have to do to better prepare surgical residents to have an impactful career in the paths that you've led?
And medical residents.
And medical residents.
All residents. Well, and beyond that, trainees for every aspect of patient care, right? I think we get very focused on what we do in the day-to-day. And we, as I said, a lot of things do piss us off. And we just kind of accept them because I've got another case to do this afternoon. I've got clinic tomorrow, et cetera, et cetera. We don't need to accept them. Now, I'm showing you 2 success stories. There are a lot of failure stories as well. We can't fix everything, but the things that are most fixable are the things that I've decided to spend time trying to fix. There are things that are not fixable or that are just so hard to fix that I know that that's not going to be something I can impact. But these both seemed, bipartisan, like saving Medicare money. These seemed like kind of the kind of things that we should be able to get through Congress, even though it's nearly impossible to get things through Congress. And even if you are working day to day on the clinical aspect of it, find the things that are important to your patients and collaborate with people who work on the policy aspect of it. When I was at Hopkins, I was faculty in the School of Public Health as well. And we had a lot of people in the School of Public Health who do policy things and who are interested in policy things and who wanted to collaborate with us on these things. The HIV societies had a lot of people who wanted to collaborate with us on these things. I didn't go to the Hill every day. I went to the Hill maybe 10 times in the period of 2 years. Boyarsky went to the Hill every day. So find people whose job it is to do that and have them do that. You also need to find some funding for this kind of thing. But again, societies have funding for advocacy. And if you find just the right thing to piss you off that you're going to fix, you actually will be able to fix it. But I think that we give up. We have a very sort of, passive view of how we could potentially impact the general policy, the things that will impact not just our patients that we're looking at, but the sort of the greater community of patients. And I would say don't have that view and collaborate with people who are dedicating their entire lives to not having that view. You can keep operating, you can keep going to clinic, you can keep rounding, seeing patients, but bring those challenges and why it's simple and why it's important. And you're the one who can express these things better than anybody else. When it came time to talk to media, I would not let our advocacy people talk to media because they didn't know, they couldn't say it in 8 words, and they didn't have the legitimacy of it all. So use what we need to be involved in when we need to be involved, and then let our other sort of policy collaborators take it from there.
Questions? Dr. McFarland is the program director.
Thank you so much. This heroic work is very inspiring, I can't tell you. Just from a clinician point of view, when you transplanted a different strain, did you need to do anything with the medications, review, change, etc.?
It's a great question. So most people we transplant are already virally suppressed on antiretrovirals. We only have like a 3-day window to evaluate a donor and their entire antiretroviral resistance pattern, et cetera, to make changes in the recipient. So one of the things we do is we take whatever we can from the donor history. And if we know that like the recipient is on sort of level 1 antiretrovirals and the donor was on sort of next level antiretrovirals, we'll change the recipient up front. But then after we do the transplant, we do a lot of more ART resistance testing on the donor, and then we tweak those things in the recipient as well. And we've seen some breakthroughs, but they've not been superinfection breakthroughs. They've been breakthroughs when the recipients just had a self-imposed medication holiday.
Excellent. Thank you so much.
I think I said I wouldn't go to ask a question, but I have a question.
Good.
Do you see a day where you will go back to Congress to, propose another bill for xenotransplantation?
Well, we are working with regulators on a regular basis now for xenotransplantation. Fortunately, xenotransplantation is not forbidden in congressional law. Xeno is a collaboration, let's say. Some might say fight, but let's say collaboration between us and basically the FDA right now. And actually, FDA has been quite supportive of the efforts of xenotransplantation. And the NIH has also been supportive of, the desire to do research in xeno. Another example is we do Hep C positive to negative transplants all the time, and we never had to get congressional permission to do that. Do you know why we didn't have to get congressional permission? Because what was Hep C called in the 1980s? Non-A, non-B hepatitis. It didn't exist in the 1980s, really, and so it was never forbidden by congressional law. So fortunately, most of what we have in transplantation, we don't have to deal with Congress.
So this concludes the medicine roundarounds portion of the symposium. I would like to thank the organizers and inviting Dr. Sergev to give this wonderful roundaround. So let's join me to give one.
We're going to start the Transplant Symposium. As you know, today we're going to speak about access to transplantation services and how having a transplantation program can impact the community. So the first talk is by our fearless leader, Dr. Carolyn Rochon, who is Associate Professor of Surgery and Chief of Transplant, and needs no introduction to the people who are sitting here, but maybe to the people out in Zoom land. So Dr. Rochon is speaking on champion access to transplant, a public health benefit, access to transplantation, a community health benefit, in the Community Health Benefits Symposium.
Thank you. So I'm very thankful that we have, again, interest in transplant and that we are so passionate about transplant here in our hospital and in our community. The impact of transplant in this community is tremendous, and the impact of transplant in this hospital is also very, very big, as well as its historical value. And I feel very lucky to talk to you about that today. So when I think of transplantation, people just think, I always remember as a medical student, there was a nephrologist with a lot of white hair who I remember he was not a believer in transplantation, and we don't see those anymore. He used to say, transplantation is a vanity project, but nobody has shown that it's truly beneficial. Now, that was a long time ago now, but I think that now we've really shown how beneficial transplant is. So it is not just a different type of renal replacement therapy, but it really, kidney transplantation helps a recipient live longer. It helps them live better. They can eat better. They can travel. They have a better lifestyle. They have a better mental health. They have better cardiac health. And they also have better mental function, which is so important. Like I don't know why they're all accountant, but I can remember specifically 4 or 5 accountants that I've transplanted, and that after transplant had told me, I need to go back at the taxes I did 2 years ago before my transplant, because I think so clearly now. I'm wondering if I was really thinking clearly when I did that before. And so the impact on mental function and speed of mental function is tremendous. The sad truth about transplantation is that despite all of our advancement, we still have enormous disparities in access to transplantation. And so I'm going to spend a few minutes talking to you about that. This slide here shows access to transplantation, kidney transplantation in Mexico. And you can see, at the bottom, you can see that the patient on the wait list, the top left corner shows you the number of patients on the wait list in Mexico has been going up every year. But meanwhile, the rates of transplantation in Mexico have really stayed the same, which is the slide at the bottom left. And you can see there that overall it's about like 20 per million population, and it's been stable there since the early 2000s. And in the United States, we're at 76 per million population, and so huge changes in access to transplantation. There might be some differences in incidence, you might say that's true, but not that great. And then if you subdivide, the graph that you have on the right is the number of patients transplanted by their county of origin, by their address county, so not where they were transplanted, but where they were born. And you can see that access to transplantation has a huge disparity in Mexico according to where people live and where people were born. And so that enormous disparity, right, needs to be addressed. And I think that as American, we go, but that's in Mexico. We're much better in the United States. So here is a difference in access to liver transplantation in the United States. And so you can see that the access to transplantation per incidence of liver disease and of listing varies tremendously according to where you live in the United States. This graph is from data before the redistricting of the organ allocation in liver that aimed at decreasing the access to transplantation disparity based on geographic location. But I think that when you look more closely, we still have in the United States huge discrepancies in access to care in transplantation. It is an area of care that has limited resources, and everything that we do has huge impact on where our field go and how the patient success it. And so it's really important that we don't only focus on what care we can provide, but who we provide it to and where the justice is and how we provide it. The graph on the right also gives you a difference in access based on a lot of demographic data. And you can see the variability that is there, how wide each of the lines are, is the differences you might find between different programs across the country. So how different patients are based on their race, their sex, their age, when they access to transplant in different counties is also still very varied in the United States. I just need to touch this a little bit. So here this graph it still looks at a geographic disparity in liver transplantation. And what I like about this paper is that it discusses that there's also differences in rate of organ donation, because there's differences in rate of preventable death amongst the states, right? So this is differences in preventable deaths in accidents in Massachusetts, South Carolina, and Florida. And how the differences are in heart disease, cancer, stroke, chronic respiratory disease, and accidents. And so as you go from Massachusetts, South Carolina, and Florida, the access to tertiary care changes, tertiary care health center changes, the helmet laws for people in motorcycles change, and therefore so do the number of what we call in the United States preventable deaths. And so interestingly, so therefore, some of our disparities in transplantation might not just come from access, but from availabilities of organs. And this is where there are some controversies in the United States, where some of the states that have more preventable deaths than other, therefore also have more donors and better access to transplant, and are debating whether it's fair to send these organs in states that have less preventable deaths and lesser access to transplantation. these are fair points. And for example, Massachusetts, which is a very safe state, has fewer eligible donors per million population than South Carolina or Florida. Florida is one of the highest eligible donor in the United States. They also have one of the fastest transplant rate in the United States. You know, in New York, we call it the fifth borough. A lot of our patients are double listed in Florida, hoping to jump on the plane if they get called. And so these are things that, when we talk about access to transplantation, because of where we get our resources in transplantation, unfortunately, these things have to come to mind. Another significant disparity in transplantation that we often don't discuss enough is the geographic location and the distance between the dialysis center where the patients are cared for and transplant centers. And this is well documented. And this slide is very busy, but the main thing to know is that this first slide here is used as the reference number of 1 if the transplant center is within 10 miles of the dialysis center, right? These patients would have an access to transplantation of 1. And if they are between 10 and 20 or 10 and 50 or more than 50 miles, if their dialysis unit is more than 50 miles, their access to transplantation significantly decreases. And this is true also of areas where distances are greater. For example, the Midwest, access to transplantation is a lot lesser than the Northeast and the Western states have one of the poorest access to transplantation. And so these geographic disparities are something that a lot of transplanters think should be addressed, and a lot of others think are sort of natural history of utilizing limited resources. Now, obesity is one of the, it's the problem, is the healthcare problem of our day. And you can see here, this graph basically shows something that's been shown, like if you Google, if you PubMed obesity and transplantation, there are papers going back to the 90s. And there's a landmark paper by Dr. Segev in 2006 that really discusses how obese patients with BMI more than 35 or have a longer time to transplantation, have a higher rate of denial for listing, and are often skipped for different offers rather than transplanted when an offer does come to them. And so the morbidly obese, which is one of the fastest rising population in the dialysis population with end-stage renal disease, is also one of the population that has the poorest access to transplantation. And so you can see here significantly below for male and for female, so female even more than for male, have a lower, when morbidly obese, this yellow line here, has a much lower access to transplantation than their skinny counterpart. And this is despite the fact that outcomes have not been shown to be worse in terms of graft survival for the morbidly obese patients. We know very well in Brooklyn the issues of racial and ethnicity difference and barriers to kidney transplant. This slide shows here, it was done by surveys sent to patients who were evaluated for kidney transplant. And what it basically shows is that a lot more Hispanic patient and a Black patient in the United States, significantly more, right? The dark lines here compared to this pale gray line, and all three, the dark line, the black line and the dark gray line compared to the white line, shows differences in perception and education and referral to transplantation, in understanding the benefits of transplantation, in understanding the importance of pre-listing testing for their access to care. And so we as transplant centers, I believe, are failing a lot of these patients by not adapting our education, our focus, and our resources to increase their access to care. These are preventable issues that can dramatically change change access to transplantation, and still are getting reported with, this article's from 2018. So this is not, the disparities are still there, and there's still a lot of room for improvement in terms of racial disparities of access to transplantation. But there is good news with regards to access to transplantation, and there is a lot of work being done in improving access, and I think we've done a lot of that work, and we're still doing a lot of that work here at Downstate, and we're very proud of it. So the access to transplantation to the elderly is something that our program has really focused on and benefited from. And this is a slide that I really appreciate, because it really shows you, what it shows you here is that this is survival benefit for patients with different functional status. And what it shows you is that all of those survival here, if you have, and this is by different sort of quality of kidneys, right, by the KDPI. So the graph up here is like the best of the best kidneys, and then the medium sort of KDPI kidney, and here you have the highest KDPI kidney, so the kidneys that are more considered, used to be called marginal. You can see the huge benefit, the survival curve here, if you see this little dotted line, that's the survival of patient on dialysis. And so all of the different functional status are having a survival that is equal. The pale blue is the patient with the worst functional status you can find. These patients' survival with the transplant is not worse than on dialysis, it's actually the same. And then everybody else who has a better functional status, no matter what kind of kidney you give them, they do better than on dialysis, except if you give them a kidney that's 100% KDPI. So the absolute worst kidney that we get called for last night, if you give that to the least functional status patient, you will, and I'm pointing at Ryan when I say that, if you give that kidney to the worst functional status, they will have a survival that is equal to that one on dialysis. And so to really drill that into the referring providers' minds, that everybody should benefit from referral to transplantation and risk assessment, and that every organ can be used to get patients off dialysis, really is the new way to advocate for access for transplantation. This is just the data that with like a couple of medical students were presenting at ATC in a little poster. And we looked at organ acceptance rates across all the different kidney transplant programs in the country. And we excluded programs that do less than 10 kidney transplants a year. But we looked at everybody else, and we said, our patients, our transplant program, we have a higher organ acceptance rates. Do they provide better access to transplantation? And we looked at race and ethnicity, at gender, and then we looked at age. And the results were not significant for race, ethnicity, and gender, but they were significant for age. And so it turns out that programs who aggressively decrease organ discard and have increased organ acceptance rates will increase the proportion of elderly patients more than 65 that they transplant, compared to programs who have lower organ acceptance rates. What is interesting is that high volume centers who do more than 100 transplants a year, do not transplant as high of a percentage of elderly. So that does make sense. It doesn't mean that they transplant a lesser number, that's being said, because they still transplant high volume. And so although their percentage of elderly is lower, but they don't have an elderly focused sort of care as much as transplant centers who do less than 100 transplants a year might have to increase. So what that says to me is that the best place for access to care that a patient who's more than 65 can find is a program that does less than 100 transplants a year with a high organ acceptance rate. And those large centers did not transplant more Hispanic or African American patient. And the programs who did provide higher access to African-American patients, where more than 45% of their patients were African-American, had actually, sadly or interestingly, a lower offer acceptance rates, lower offer acceptance rates of high KDPI kidneys, so those riskier kidneys, lower offer acceptance rates of hard-to-place kidneys, which are kidneys that we're high utilizers of, like the kidney that everybody else has said no to. And what is also important to say when we talk about changing access to care and decreasing organ discard is that often organ acceptance rates and transplant rate ratios, right? The rate at which you're expected to transplant patient to be equal to national average, were in no way related to the program's risk of graft failures. So one of the big reasons why a lot of these centers are skipping on these organs is the fear of poor quality. But centers who accept these kidneys with high rates are not centers who have lower outcomes. Which is some of the things I say often, right? Like, if the kidney worked before, it's going to work after. It's just we have to master the art of keeping the patient alive until it works. And again, this is to sustain the idea of being high organ acceptors and improving access to care. The line here that you see is the rise in risk of death on the wait list as a patient increases their rate of organ refusal. So if a patient gets transplanted and has only had 2 offers that were refused from them, they die on the wait list at a much lesser rate than those who've received 10 offers that were refused, right? So programs who constantly get offers for their patients and refuse them have much higher rates of death on the wait list than those who accept organs and get their patients transplanted. And so if you're an elderly patient or a frail patient or a patient who has a short window to get listed in a conservative centers that is not a high organ acceptors can actually be a death sentence. And I think to strike the mark, I think that some of the bad consequences in transplantation of being so regulated regarding graft survival is that people forget about the survival benefit of transplantation and only focus on the potential graft survivor. What you see here is the traditional survival of elderly patients in the community, and see how much it drops once a patient more than 70 starts dialysis. So bringing that patient out of dialysis and back into a functional community member raises their potential survival a lot, and should not be dismissed for the sake of potential good outcome. This is, and at the same time, elderly patients, but at the same time, the expertise and collaboration of centers who wish to transplant the elderly with specialized care, geriatric care, and big support is important, because once you've transplanted a patient who's more than 70, if they have graft failure, the risk of death is enormous. So once you've decided to put a patient with a hazard ratio of more than 4, right, for death. So once you've decided to put an organ into an elderly patient to keep that graft and sustain that graft viability is the most important thing that will keep them alive. Now, transplant has a long-established survival benefit, even though this remote nephrologist, when I was a medical student, doubted it. And this is a very old New England Journal of Medicine study from 1999, right, that had shown, this is when we started to quote it, that had shown that the survival benefit of transplant comes at 90 days on average. So once a patient has survived 90 days from their transplant, now their survival post-transplant is exceeding the statistical statistical survival they had on dialysis, right? So it's 90 days is when you derive. So if you're able to survive 90 days from transplant, you will survive, you derive the survival benefit from transplant. And that, what is shown here in the left graph is that that 90 days is an average, right? The patient who is more than 65 actually takes them a year to get that survival benefit, but the patient who is 19, it takes them 3 days to have a survival benefit. So the 90 days was an average back in 1999. But this is a study from 2004 about the survival benefit post-transplant, and it shows that for patients more than 70s, the survival benefit is now at 9 months. And so if a patient survived 9 months, more than 70-year-old patient survived more than 9 months post-transplant, they've derived a survival benefit from being transplanted. And that survival benefit is true at all ages, but of course here in the graph to the right, you show that the older the patient, the greater the benefit until you hit about 80. This is, what I alluded to before, that access to transplant for the morbidly obese is important, and that once these patients are transplanted, their long-term graft survival and patient survival is much greater than if they stayed on dialysis, and it is not different than non-morbidly obese patients. And so I just want to wrap things up by discussing what we do here at Downstate to be champions of access to transplantation. So we use data-backed tools to assess candidacy in the elderly, and we really deep down and focus and have deep team conversation about each of our referred patient above 65's candidacy, and we really try to use data to deny people, not just looks and nice notes in the, and you'll see us, if you join our meetings, you'll see us use these tools at every single meeting. We have no BMI cutoff except for patients who are less than 65 and no peripheral vascular disease and have no CAD, which is consistent with the literature. And we use a diverse team who is a member of the community, understands our patients' barrier, and helps them get the care that they really need and deserve. And you can see here, this is our latest SRTR report that shows that our transplant patients are 98% non-white, which is representative of the community we serve, and I think is representative of how there is disparity for access in these patients, and they feel good in our healthcare system, and they know that the best care for them will be provided here by the people who care about their outcomes. And our ratio of elderly is higher than the region and of the country. And that's all I had. Thank you. Any questions? All right. So if there's a question. Oh, yeah.
Before we talk, how should we be thinking about higher KDPI kidneys and transplantation younger? Obviously, you're causing the population to be older in your transplant center when you're accepting higher KDPI kidneys. Is there some understanding that you're being careful with the younger patients?
Absolutely, and we see this all the time, and I wouldn't say, so I like to, so KDPI is just statistics, right? And sometimes oh, good. And sometimes because of, you'll be surprised how a donor might have a small history of hypertension, and they showed up to the hospital in AKI, and all of a sudden the KDPI is really high. Meanwhile, this person has perfect kidneys, and the KDPI is high, and everybody's starting it down. So one of the big discussion in transplant is not all KDPIs are born equal. Also, KDPI is a ratio, and it discusses and it entertains all kidneys that were used in the past 2 years, right? So as we learn more about kidneys and we become higher utilizers, then 99% this year was probably not used a few years ago, and now that the organs that we now use will be part of next year's 99%, but were not used 2 years ago, and so something that is 85 today will probably be 80 in 5 years that we expand access, because that's how the KPI keeps being recalculated based on the organs utilized 2 years ago, if that makes any sense. So the higher KDPI kidneys definitely, or their longevity is increasing every year. And as we become better at sustaining the GFR of these grafts also, and dealing with the initial DGF, delayed graft function that they might encounter, because they weren't like just the perfect machine that the 20-year-old kidney might be. But more importantly than the high KDPI, I think what we're very good at utilizing is that what I call the overlooked kidney, the 30-year-old kidney that creatinine rose to 7, but had no kidney disease. This is just a kidney and the whole country is turning it down. And we've been utilizing these kidneys a lot into elderly patients, because we're like, we don't know how this kidney is going to behave. And then, you know, when the 75-year-old has a creatinine of 0.8 at 3 months, we all say, maybe we should have put it into the 55-year-old who's been waiting for a while. So I agree with you. I think that, you know, there is a shyness in the middle of the night when your number, like, 7,000 in the country for a kidney, and you go, wow, everybody else in the country doesn't like this kidney, but I think I can make it work. And I don't want to be too arrogant and also give it to a 50-year-old. But I think we are in the process of learning from this high acceptance behavior and bringing it back to benefit those who have the longer expected post-transplant survival, as you're pointing out. I don't know if that answers your question, but overall it's a yes. We're getting better at making them live long and utilizing them in all patients. Thank you for that question. So I just want to now move on to introduce Dr. Markel. Dr. Markel is our esteemed medical director, and she needs no introduction. She's been at the center for, I think we just said this morning, 5 years at Downstate. And a little over 5 years, and she's going to discuss something that is really passionate to her. It's encouraging wellness behavior in the post-kidney transplant patients, diet and exercise.
Thank you so much, Dr. Marchand. Okay, so I have nothing to disclose. So today I want to very briefly talk about how can having a transplant center in our community improve overall wellness in the dialysis population? And what is the definition of wellness and the adverse effects that social drivers, which were called social determinants, could have on wellness in our population? And then talk about a couple of strategies for cardiac risk reduction, including diet and exercise programs. So I think you just saw this slide. The closeness to a transplant center, as you could see, especially in a metropolitan community like ours, the closer you are, the more likely you are to get a kidney. And the closer you are to have a transplant center in your community, your dialysis patients whom you've referred will have an improvement in their wellness behavior. Because as you know, patients who are referred for pre-transplant evaluation get a very careful workup. And one thing we've looked at are patients in dialysis units who have not gone for transplant evaluation, and there's not as high a rate of patients who've gone for, say, cardiac evaluations. We evaluate everybody with an echo, and then a stress test or a PET scan or angiography is needed. These patients all are required to get routine cancer screening, which patients otherwise may not be doing, including colonoscopies or Cologuard, mammograms and pap smears per guidelines. So just having a patient referred for transplant will automatically increase that aspect of their wellness care in dialysis patients. In addition, all of our patients see social work, and they're assessed and referred for services if that's discovered that they're needed. And they'll see a dietitian, and they will be screened for frailty if necessary, then referred for dietary counseling. And I'll talk to you a little bit about the possibility of prehabilitation for these patients. So just from being referred for a transplant, patients are encouraged to undergo all of these wellness behaviors. So what is wellness? wellness can be defined as occupational, physical, emotional, spiritual, intellectual, and social. Those are the 6 dimensions of wellness that were defined in 1976. And those come in conflict with some of the social drivers, which used to be called social determinants of health, which again, I'll remind you, are the neighborhood and built environment, health and healthcare, social and community context, education, and economic stability. So how would social drivers have adverse effects on wellness in our population? Well, occupational includes lack of well-paying jobs that are available, and certainly for dialysis patients, no jobs may be available, or for patients post-transplant, poor working conditions, inadequate availability of good schools and poor support for educational programs for not only the patients but their children, spiritual issues which can include feelings of hopelessness and difficulties in getting to attend worship services because of transportation difficulties, emotional issues including exposure to violence in the community, difficult family situations, a lack of feeling of community, and as I said, poor transportation can affect social issues as well. And then the physical, which is what I'm going to focus on more, which is poor availability of high-quality medical care, easy availability of poor nutritional choices, lack of affordable fresh foods, and difficulty in accessing safe and affordable places to exercise and walk. You can encourage patients to do exercise, but as one patient once said to me, I think it's more dangerous for me to go out and take a walk than it is for me to sit home and just watch TV. So, I mean, they were being somewhat facetious, but unfortunately, given some of the neighborhoods around New York City, that may be true. And a quote that I always come back to is, our zip code may be more important than our genetic code. So in fact, lack of available healthy food is considered a food desert. And Brooklyn is not a true food desert, but many areas are. And in the United States, about 11.5 million people, or 4%, live in low-income areas that are more than 1 mile from a supermarket, which is the definition of a food desert. Unfortunately, many of those patients live in what's called a food swamp. And a food swamp is an area where there's easy availability of fast food and cheap, unhealthy alternatives. The bad news is that, in fact, East New York is one of the biggest food swamps in New York City. And any of you who drive down Pennsylvania Avenue know that there's a very high concentration of fast food restaurants there. In zip code 11207, there are 27 and 14 in 11208, and this is old data. There was a 14% increase over 10 years. And in fact, living in a food swamp may be as deleterious as living in a food desert. So what happens with food insecurity? There's economic instability as well. And Brooklyn and the Bronx have the highest rate of food insecurity of all of New York City. More people in our catchment area skip meals than almost any other area in New York City. And you can see, again, these are old data, but this area should look very familiar to us, and that is the highest area with food insecurity in New York City. What effect does food insecurity have in terms of medically? Well, in a study that was looked at in patients who had diabetes, those who were food insecure had, not surprisingly, increase in hypoglycemic episodes, as well as higher healthcare and ED utilization, a higher hemoglobin A1C, actually a higher BMI, poorer health-related quality of life, and an increased difficulty in following a healthy diet, which included lower fruit and vegetable intake. And if you think about it, someone who is food insecure may have a cyclical availability of money for their food. And in animal models, it looks like cyclical food availability causes the person or the animal to seek out high-fat, high-caloric food. And so in fact, although it may seem counterintuitive, many people with food insecurity actually have a poor body composition. The second issue is health literacy. And health literacy is defined as the ability to obtain, read, understand, and use healthcare information in order to make appropriate health decisions and follow instructions for treatment. A subcategory of health literacy is nutrition literacy, which is the ability to obtain, process, and understand basic nutrition information. And if you think about it, you can prescribe something for a patient, either a diet or a medication dose. If they have if they can't calculate or they can't read, they're going to have difficulty following instructions. And if they have numeric illiteracy, they have a very difficult time calculating what they should be eating. You can tell a patient you should eat 2,000 milligrams of sodium a day, but if they can't figure out how to calculate that, they're not going to be able to do it. Physical factors can affect literacy as well. So visual ability, we just did a study, and our patients, many of them have poor visual acuity, but they won't tell us. And these patients may have diabetes, some of the elderly, they have cataracts that haven't been taken care of, and they're sight impaired. The font of food labels or prescriptions may be very small. Secondly, they may not be able to read, and they may feel uncomfortable in telling you this. Their native language may be other than English, and many of the instructions they're given are in English. They may, as I said, have numeric illiteracy, which is the inability to understand portion size or medication dosage, and an inability to calculate nutrient intake. And one of the studies that we did here in our hemodialysis and transplant patients using something called the newest vital sign, the mean literacy score was only 1.93 out of 6. Only 18% of the patients scored for adequate literacy, and over 80% were considered to be at risk for illiteracy. So I think one has to be very careful when encouraging wellness behavior in patients to know who the patient is in front of you so that you can meet them at their level and explain behaviors in a way that they understand. So I want to go on then to talk, and then this is the same thing. 81% in the study had seen a dietitian for dietary counseling, and 15 in the past year. But in fact, very few of them scored well on the healthy eating index, although 66% believed their diet was healthy. And the interesting thing, though, was that the low literacy patients, although they were older, they weren't different in terms of their healthy eating index or education or income. So I think overall our patients had a fairly poor diet quality, despite the fact that they were getting monthly dietary counseling when they were on dialysis, and they also saw a dietitian after they were transplanted. So how can we approach wellness strategies in our patient populations? You know that cardiovascular risk is increased in both patients with end-stage kidney disease who are on dialysis as well as those who are transplanted. They have traditional risk factors, including hypertension, dyslipidemia, diabetes, and tobacco abuse, but they also have non-traditional risk factors like left ventricular hypertrophy, mineral bone disease, inflammation and oxidative issues, and then the presence of immunosuppression. This all leads to cardiovascular disease, which includes heart failure, pulmonary hypertension, arrhythmia, and coronary artery disease. So the point is to encourage wellness behaviors that can offset this. The routinely recommended, and this is the KDIGO and American Heart Association recommendations, are to treat hypertension to a target, to treat dyslipidemia. In fact, interestingly, they recommend in this paper use of statins in all kidney transplant recipients, keeping the target hemoglobin A1C to 7 to 7.5%. And here they recommend a BMI of less than 35, which is a relatively, I think, is not a particularly strict recommendation. But as you heard, we are trying to widen our access to transplant for patients who are in the more obese category. And so patients who are over 35 kilogram per meter square BMI, we should be recommended to have some sort of a approach for weight loss. And then, of course, to stop smoking. So these cardiovascular risk factors are modifiable by diet and exercise. I think everybody knows this: high blood pressure, hyperlipidemia, glucose control, and then body composition, especially visceral adiposity. And so one of the things that's been recommended recently is the plant-based diet. So how would a plant-based diet help with cardiovascular risk? There is theoretically much less inflammation in a plant-based diet. The meat-based diets are associated with release of pro-inflammatory cytokines. A vegetarian diet may, as I recently said, as I will show you, may decrease risk factors such as hypertension, diabetes, and hyperlipidemia. And if a patient decides to become vegan, which is not necessary, you can see a difference in their bacterial flora in their intestine, which may improve their microbiome. This is just a look at the prevalence of hypertension in patients who follow a plant-based diet. Again, they may follow other healthy lifestyle choices as well. But here you can see that even a semi-vegetarian, so it is not necessary to go completely vegetarian, has a lower risk of hypertension than somebody who is a meat eater. And again, patients who are semi-vegetarian have a lower risk of diabetes. And again, this is not in patients with kidney disease, but this is in all patients, just looking at population studies, trying to account for other healthy behaviors, but many people who follow a vegetarian diet may have other healthy behaviors as well that are playing into this. Be that as it may, there are other reasons why the adoption of a plant-based diet might be recommended for our patient population. So a plant-based diet is a diet rich in vegetables, fruits, legumes, and minimally processed foods with limited or no animal products. It does not have to be a diet that is completely devoid of animal products. And interestingly, plant-based eating is actually associated in population studies with a lower incidence of chronic kidney disease, also a lower incidence of albuminuria. So it looks like plant-based eating may be good for the kidneys, certainly before transplant, and probably after as well, although those studies haven't been done. But how could plant-based eating help? Will it even help in pre-transplant help, in dialysis or patients with CKD? Well, it does cause, as I said, changes in the gut microbiota, which may alter the presence of some of the uremic toxins. It also has, patients are able to eat more protein because, as I'll show you, phosphate is less bioavailable in plant proteins, and so patients can eat more protein, and there's a lower acid load. Animal proteins actually are high in acidic amino acids, such as the sulfur-containing amino acids, and it has been shown that taking bicarbonate may slow progression of kidney disease. So the thought is, because plant-based diets are highly alkaline and result in a decreased acid load, that this may be one of the drivers for the improvement or the decrease in chronic kidney disease that's seen in patients with chronic who are plant-based eaters, and the decrease in possibly risk for kidney disease. And this is just showing you acidic foods versus alkaline foods. In addition, as I've mentioned, plant-based phosphate may be less bioavailable. In fact, plant-based phosphate is bound to phytates, and so it's less digestible. And so for a given protein intake, in this study, patients who followed plant-based diets excreted much less phosphorus in their urine. Obviously, these weren't dialysis patients. So one of the issues in patients who are pre-transplant is protein-calorie malnutrition. And theoretically, encouraging plant-based eating in dialysis patients may keep them healthier going into transplantation and possibly after transplant as well. And just to remind you, as I said, it is not necessary for patients to become vegan, in which no animal products at all are eaten, or vegetarian, although vegetarian usually includes dairy and eggs. Patients may be pescatarian, and they may be flexitarian. So the Mediterranean diet, which includes small amount of meat, mostly fish, nuts, olive oil, and some wine, as well as the DASH diet, can be recommended, and both of these diets have been shown to actually be efficacious in patients with kidney disease. Now, the old recommendation was not to use the DASH diet for CKD stage 4 or higher, and that was because of worries about hyperkalemia, high potassium. In fact, that doesn't seem to hold water anymore. And again, as I'll mention, the issue with hyperkalemia in a patient who is very careful about their potassium intake is probably not one to prevent them from following a DASH diet. But one has to be careful because there are what are called junk food vegans. Oreos and French fries are plant-based, And in addition to that, vegans may be at risk for, if they're actually vegan, they need to supplement B12. Vegetarians often get enough B12. And vitamin D is probably necessary in everybody who lives in Brooklyn, but it certainly may be necessary in patients who avoid dairy products. The other thing to realize is some of the meat products are extremely high in sodium. They're trying to get away from that, but things like Beyond Meat, Impossible Burger, those things are very, very high in sodium. And in fact, a patient who follows an unhealthy vegetarian diet is also at risk for coronary heart disease. You no longer get the actual benefit. And so it is good to have a dietitian speak to your patients who are interested in adopting a plant-based diet. One of the things patients may tell you is that they can't afford it. In fact, that's not true. There are many, sorry, I skipped ahead. So this was the issue about high potassium, and this recent study suggests that plant-based diets do not result in hyperkalemia as long as the patient is educated about which are the high potassium foods. And in fact, not everybody with late-stage kidney disease needs to restrict potassium, and many of our transplant patients don't need to restrict potassium at all. And so there's no reason for this to be a concern. The other thing is that there are cooking techniques, such as boiling, that can lower the potassium content of food. But again, it's important for the dietitians to speak to patients about this. And then, as I said, some patients will tell you they feel like that vegetarianism or veganism is going to be expensive for them, but in fact, many plant proteins are quite inexpensive, and some patients actually have it as part of their ethnic diet. Things like rice and beans, potatoes, beans and broccoli, things like that. So in fact, fresh fruits and vegetables are covered by many of the food programs now, and so patients should not be, avoid trying to eat more of a plant-based diet because of economic reasons. Then finally, please remind your patients that they don't have to give up eating meat in order to get the benefits. One of the things that I've heard from patients is, I really like my steak. But the point is that to add meat as a garnish rather than a main dish, and that even eating maybe plant-based once or twice a week, meatless Mondays, doing something like that, has been shown to have a benefit. So in the rest of my time, I'm going to talk about frailty. So as some of you heard last night, frailty is defined as a significant decline in functional reserve, and it results in an extreme vulnerability of the individual. And the famous Fried phenotype of frailty includes a slow walking speed, decrease in grip strength, unintentional weight loss, declining physical activity levels, and exhaustion. So extreme frailty is a contraindication to transplantation. So the point is to try to prevent patients from developing that prior to your referral for transplant. And why is that? Well, in fact, in patients with CKD, about 14% of them are frail, and there's an increased risk of dialysis in those patients and death. In patients who are transplanted, about 20% of them are frail at the time of transplant. There's an increase in death on the wait list. They don't get transplanted. There's an increased length of stay. They get rehospitalized. There is a question that they may have an increase in delayed graft function, decreased cognitive function, and death post-kidney transplant. And for patients who remain on dialysis, the patients who are over 65, the estimate is that almost 70% of them may meet a frailty phenotype. Those patients have decreased cognitive function and quality of life, as well as falls, death, and hospitalizations. So the point is, it's very important to be aware of frailty in your patients, and to figure out, is there some sort of a wellness behavior that we can do that will help that. And again, just to show you, this is a slide that Dr. Segev's group actually was responsible for, and it's just showing you here that if you transplant someone who is frail, you have adverse transplant outcomes. So how can you prevent frailty in the dialysis population? Well, the one way is through exercise, which I'm going to talk about. Another way, as I mentioned, is encouraging nutrition, obviously encouraging healthy nutrition and not poor nutrition, comorbidity management, and then senolytics, although there really are no senolytics that I know of that have been used in dialysis patients successfully, but that is a pipe dream. So the point is to try to decrease things like inflammation, muscle atrophy, and malnutrition. And one of the ways that this has been done is to try to create some sort of a pre-transplant exercise program. Dr. Segev last night told us about a program that they've used where they have pedalers for patients to, they pedal while they're on the dialysis machine. And here you can see this is another study that was done with intradialytic cycling. They also had very, very low weights, and they had patients actually do weight training during the dialysis, and then they encouraged them, they gave them pedometers and encouraged them to walk. Then they did another approach where it was really more of a wellness approach with comprehensive lifestyle modification, where in addition to their intradialytic program, they encouraged them to join a gym, and they actually encouraged them to do exercise that was very low intensity when they were not being dialyzed, to walk more, to walk their dogs, to go to the supermarket and maybe park a little further away, to try to use some, sweep up or do some cleaning around the house, things like that. And they really educated patients that that is in and of itself exercise, and to just, be aware that sitting and watching TV all the time is not good for them. So, these actually all had impact on their ability to, on their frailty. So we actually recently did a study where we interviewed 35 of our kidney transplant recipients and looked at frailty as measured by their hand grip dynamometer, averaged over 3 measurements. And then we did a body composition study using an S10 body composition analyzer. And what we found was that actually only, that 43% actually did have some sort of an exercise plan, although the majority of them did not. But they really did want to learn about more about exercise. More than half of them were interested in some sort of an exercise plan. Of the patients who did have an exercise plan, what we looked at was something called whole body phase angle. And what that is a measurement, they call it of cellular integrity, but in fact it correlates extremely well with frailty. And the normal values go between 5 and 8. So you could see that the patients who had reported that they do weight training had a significantly higher whole body phase angle that was in more of the normal range than those who did not have weight training. And these are just randomly selected kidney transplant recipients. And they also, not surprisingly, had a significantly greater skeletal muscle mass than those who did not do weight training. And of those patients who did not do weight training, some of them actually did aerobic exercise, but they still had a lower muscle mass and lower whole body phase angle. So I just want to say that, in summary, having a transplant program in your local community definitely increases the chance of being listed and eventually receiving a kidney transplant. It also encourages wellness behaviors in the dialysis and CKD patients who are referred because of the requirement for things like screening for cardiovascular disease, things like colonoscopies, and screening for cancers and general wellness recommendations. However, adverse social drivers, especially in our population, should be recognized because these do serve as deterrents even in the most motivated patient. And ongoing pre-transplant wellness approaches may include things like encouragement of plant-based eating and a graded prehabilitation exercise program, as frailty is associated with poorer transplant outcomes. So I think, in conclusion, I hope I've shown you that having a kidney transplant program in a community, especially one with adverse social drivers, creates many both potential and actual benefits for the patients we serve, both the dialysis and the preemptive CKD patients. It increases access to transplant and fosters wellness behavior both in the pre- and post-transplant period. And this is just some information about plant-based eating. Thank you. So, questions? No questions? Any questions? Dr. Suresh is going to speak about surgical barriers to transplantation.
Still good morning. All the talks before had a lot of data and everything. Mine is going to be a very simple surgical talk about what the barriers for a renal transplant patient from a surgeon's standpoint. It's a very basic talk. So this is how we do transplant, right? Transplant is, that's our abdomen, picture of our abdomen. You can see the God-given 2 kidneys which have failed and the new kidney which is given by man. We have three connections, one to the artery, one to the vein, one to give blood, one to take away the blood, and the ureter anastomose to the bladder down there. Another picture there, something very similar. See this is how we do it. And believe it or not, I'm going to show it in the picture next. The kidney resides where? Not in your belly, outside your belly. What in the medical term is called retroperitoneal. You put it most of the times outside the belly. So to start off with a little bit of history, actually the first transplant was done by actually a plastic surgeon along with Dr. in Brigham, Dr. Murray. He did with monozygotic twins. So when we start talking about transplants from a surgeon's standpoint, it's a technical operation. But is that all we need to do a transplant? So we have there's a lot of trials that have gone on, experimentation, whatever we've done. How did we come? Who are the stakeholders? First and foremost, somebody's kidney fail, like Dr. Sege was talking, you in South Africa, your kidneys fail. The next step is you don't make it. Right? The first step you need is renal replacement therapy. So we need nephrology where we can support them till you can give them a transplant. Second is who gets which kidney? How are you matching? You got to match them. You got to understand the HLA antigens, blood group matching, what needs to be done. And the next step is, yes, you're going to transplant, but not all the time you have the patient next to you who's going to take the kidney and go in. But you have to find how you're going to preserve this. What is the best way to take the kidney from the donor to the recipient, whether it's living, deceased. Fourth is the topic, surgical barriers or technique, how we do them, and how it was done before. And after this, again, we need how to overcome the immunological barrier, where the patient has to keep the kidney for himself. How do we do this? These 5 steps are the stakeholders doing transplant. We're not going to talk about all this, too much. We're just going to talk about point 4, surgical barriers, how we can do this. So, first and foremost is a stable hemodynamics. If you don't have a strong heart, you can't go into general anesthesia. If the heart isn't up pumping, the kidney doesn't receive blood. Normally, 25% of your cardiac output goes to your kidneys for filtration purposes. So if your heart is not strong enough, your kidney transplant ain't going to work. So it's very important to have a good cardiac restratification to see if this patient is going to be a candidate and this transplant is going to be viable. Next, what are we going to talk about today? Place to implant. I need a place to put this kidney where I can give it an inflow that is oxygenated or blood from the heart that goes in, and a place for the blood to exit the kidney and go back into the systemic circulation. Inflow, outflow. And the last is you need access to the genitourinary tract. Means the kidney produces urine, so we got to get this out. So it could be bladder, it could be the native ureter, it could be something else. We'll talk as we go along. So 3 important technical aspects that we need to be able to think about before starting the journey. So next is a brief video. Okay, this is how we do a transplant. Most of the time we make incision the right side or the left side, which is paramedian next to the muscle, the 6-pack we see in the movies. You go through the skin, and that's your scarpa's fascia, what we see. So once we go through that, what we see, the white layer is called the external lobular aponeurosis, which covers all the muscle. We expose that. That's the muscle. Sometimes we can spread the muscle, or we go through the muscle spreading incision. We spread the muscle. That we see is the preperitoneal fat, and those are the inferior epigastric vessels which are there, which are usually divided, or the cord, whichever you can think. And in men it's the cord, in women it's the round ligament. We divide that, and that's the peritoneum. We'll push it, and you have access. So you're outside the belly. So that's back is the psoas muscle, also called the fillet. People who eat steak. That's your vessels. This is the external iliac vessels. Right above is the aorta there. And what do you see? The internal iliac vessel, external iliac vessel. The common iliac is becoming 2 parts, internal and external. This is the kidney, which is sent to us on a pump or in ice. Like you say, has 3 connections. The red is the artery, the blue is the vein, and the yellow is the ureter. So we bring the kidney in, place it, and we clamp the vessels so that there's no blood flow in the part we're sewing, because you cannot sew while you're doing it. Okay? We move the artery away. You clamp it so there's no flow. You make a venotomy. So suctioned out. You sew it. It's called the end-to-side anastomosis. You suture it. You leave the clamp in place because you don't want warm blood entering. This is still, it's out of ice. Once the kidney came out of ice and we started sewing, started our warm ischemia time. That marks the end of the cold ischemia time. Now, we clamp the vessels. We see at 2 different spots to prevent blood flow again. And again, the same thing, end-to-side anastomosis. Here, what they use is an air punch, where we can punch a hole in the vessel because we want the flow to be good, or you can just do a slit. You do end-to-side anastomosis, and then once you're ready, this is the most important part, you have anesthesiologist in the room, and you release your clamps, marking the end of warm ischemia time. It's still, yeah. So the kidney is receiving blood. Now you will see urine coming out, especially if it's a living donor. Now you reposition a retractor, you find the bladder. The ureter is put under the cord in men. For women, you spatulate it. That's what it's called. What they did with the scissor right now is called spatulating it. So you have a wider surface area. You make an incision. That's the muscle on top of the bladder. You remove it, and that's the urothelium. Once you open it, you see water coming out. Usually you would have filled it with water or a 3-way Foley. This is what they're doing right now is called the Leach-Grigor technique of anastomosis, where you close it. But here, Dr. Kountz created a new technique, what we call the single-use stitch technique, which we use, which has been very successful. And then you close the muzzle on top to create an anti-reflex mechanism. Because every time you pee, the bladder contracts, it kinks the ureter so that the urine doesn't go back into the ureter and causing pyelonephritis or UTIs, which is not as effective, but it's effective in some places. So that marks the end of your transplant. You push peritoneum back, you close up the fascia, leave the muscle. I tend to leave a drain. Dr. Roshan doesn't leave a drain. They're both screws up top. And you close up, and that's your transplant in a nutshell, right? Key is access, and planning matters. So now, since we understand how transplant is done from a certain standpoint, we can go to the next step. What are the barriers to doing this, right? There are many. I just listed 4 for the purpose of the talk. 4 common things we see here at Downstate. Peripheral vascular disease, morbid obesity, bladder issues, somebody who's had problems with bladder, it could be any side, and retransplant, right? So these are the 4 things. So we'll go one at a time. So start off with peripheral vascular disease. What does that mean? We are using blood flow that goes to the lower extremities as our inflow to the transplant, inflow and outflow. So if that blood flow to the leg is already compromised, we can't be using that, right? Most of the people have high blood pressure and diabetes. The vessels, because of chronic disease, including end-stage renal disease, have these things deposited in them, which we call as atherosclerosis, that makes us putting those clamps, which you saw, very difficult. If I put a clamp in something that's become like a lead pipe, you crack the vessel. Not only you're not going to be able to put the kidney, you lose the blood flow to the leg. You compromised it. So that's why we end up getting CAT scans or various workup to see how these vessels are, what is the native state of these vessels where you're going to be putting this kidney. So when we see on CAT scans there's a lot of calcification or there's no flow sometimes, it can be a soft plaque which cannot be seen without a contrast, then we have to plan appropriately. So this is the main problem when there's a narrowed blood flow. And there are different types. We'll go through one at a time. So this is another close-up view how it looks. This is a bifurcation, most common. That's the aorta on top there, and that's the common iliac bifurcation. The most common point where this happens, and this affects our inflow, blood. So wherever you put the kidney, we put it on the external iliac artery. This common iliac becomes external, going to the leg, internal, supplying the pelvic organs. This area is the most common area where calcification occurs because of hemodynamics. And when this happens, you're losing the blood flow to the kidney. There's compromised flow to the kidney, or you put your clamp there. We recently had a patient, and that vessel will crack, causing dissection, and your kidney doesn't get good flow. So it's something to keep in your mind in the preoperative workup. Look at this CAT scan here, which we see all the time. There's no flow, there's no inflow there. There's no way you can put a kidney on the right side. Whereas the left side, yeah, you have some, can I move my mouse here? Yeah, I can. Oh, everybody can see. Okay, so you can see no flow here. There's a lot of collaterals that is sort of able to supply blood to the leg on a normal, this person, if he walks, he probably will have right lower extremity pain, because this blood flow is not going to be, the blood is not flowing through a highway, it's going through a parkway. So eventually reaches the leg in a resting condition, but he strains that leg, he'll have rest pain. The left side is pretty okay, but though it's calcified, you can see all the calcifications. So, this is something we do here at Downstate. We are able to take these high-risk cases, and we find a small sweet spot there, and we're able to put these kidneys. You have to plan them very well. Usually you have to have a clear planning, not an old CAT scan. See if there's a spot where you can put these clamps, or sometimes the clamp you put may not be adequate, like complete hemostatic, but you still can get the kidney in place. This is something that's going to be impossible, right? It's called monkey bug calcification. There's calcifications all over. It's almost impossible to do it, but we have done a couple of these cases, but involves a lot of risk. As you can see, the aorta is got, this is a mini aortic aneurysm here. You can see a small one, probably about 4 centimeters. And then as you go along, you see these calcifications that make it very, very difficult to put your clamps. So doing a kidney transplant in somebody like this, it's going to be very difficult. Another picture where it's completely calcified all over. So this probably precludes this person from getting a kidney transplant. So look at this here. This is a case I want to show when somebody has such bad peripheral vascular disease. You can see this is a stent here. It's inflow stent. It's an old CT. Usually you don't do this because it sort of impinges on the right side. What we do now in vascular surgery is called kissing stents. You put stents on both sides, but here there's only one stent. And again, there's another stent in the external iliac artery on the right side. But this is a case which probably we do it here at Downstate. So you can actually put a kidney on the left side here. See, there's a spot here. You can probably get it in. But to do that, we have to improve inflow here on the left iliac side. If you can do that, this is something, though it looks precarious, but this is something we can do. So that was about inflow, outflow, and doing transplant. Next step, we go is morbid obesity. This is a topic of contention between me and Dr. Rashan. So this is description of what obesity is described, right? Somebody is below 25 is a movie star, 25 to 30 is overweight, 30 to 35 is obesity, 35 and above is morbid obesity. If you look at the Medicaid guidelines, anybody who's got an obesity above 35 with sleep apnea, diabetes, or hypertension, even including arthritis now, gets qualified for a bariatric surgery. But what are the types of obesity? So when we look at BMI is just like a number, like we spoke in the talk earlier about KDPI. It really doesn't, it's a number. You cannot look at a number to make what's happening here. In the last picture here, this patient will be a perfect candidate for transplant. It doesn't matter. The problem happens in the first picture and the third picture. Even the fifth one is all right. It's when you have centripetal obesity with the overhanging pannus. That's where it is. Is it not doable? Yes, it is doable. You have to have techniques to minimize the risk of complications in these patients. What are the complications? It's difficult surgery, bigger incision, wound complications. But do the grafts do well? Yes. The grafts do fine, but if you can get them better before you get them to the transplant, where we go through the intervention. What are the interventions? Many of these patients get obese not because of eating. 30 to 40% of these patients have mental health issues. They need to be evaluated by a social worker or a psychologist why they're overeating. Because the reason you get there is because of something else that's going on in your life that leads you to there. So you really need to be evaluated by a nutritionist and a social worker to figure out why this started. And then come up with formulate a plan how you can do this. Is it possible by lifestyle changes realistically, or does it need any other intervention? So this is just to get the patient better, but it should not preclude somebody from getting a transplant. Because if somebody is young, like we are going to be doing a transplant in our list, the person got a bariatric surgery, his diabetes is getting better, blood pressure gets better, sleep apnea gets better, weight loss is there, you do a transplant, you're like overhauling the patient. They get better from all aspects. Your post-transplant care will become much easier. But is it absolutely necessary? No. But the way you optimize the patient with respect to weight loss and sustained weight loss is what makes a difference. So bladder issues. We see all the time bladder cancer, neurogenic bladder, posterior urethral valve. There are many issues with respect to bladder. So you need access to the genitourinary tract because the urine has to go somewhere. So there are many ways of doing it, right? If somebody who doesn't have a bladder, you can do an ileal conduit, you can do mains before we go there, when we know somebody has a bladder issues, you work up. Voiding cystic erythrogram is one, with post-void residual is a urodynamic study to figure out, is this bladder going to work or not? But why do we need to do that? Because when somebody has a bladder issue, it's not excreting well. The main problem we see is recurrent UTIs, which can take a toll on the kidney and have graft loss. So the key is we have to have a clear plan established how we're going to get the urine out of the patient's body. A clear plan. So once you've done appropriate workup, then preoperative, if you have a plan, how are we going to do it? Ileal conduit, mains pouch, cock pouch, Indiana pouch, bladder augmentation. All these things can be done, and the results are excellent. The most common problem you see when you do these are electoral abnormalities, which are very easily correctable, supplementation and close follow-up. UTIs. UTIs are the main cause of problem when somebody has a bladder issue because of recurrent, they lose the graft, is mainly not because of rejection, not because of other things, it's UTIs. So that's something to consider. Retransplant, like we said, we have God given 2 external iliac arteries. You use them both up, you have to plan the next. So to simply give you a small picture, right? We have this picture here. Now, we put a kidney here. It's on the common iliac. Normally, we put it on the external iliac here. You put it on the external iliac here. So now, once we used up, we can go up to the common iliac. We can go up on this on a common iliac. But usually, somebody going through 4 transplants is rare, right? Because usually something else takes over and it doesn't happen. So the most important thing you have to figure that out is it going to be retroperitoneal? Are you going to do intraperitoneal transplant? And you probably have to do UU if you cannot have a ureter long enough to reach the bladder. So planning is important. We've done retransplants here. Number 3, we have done here number 3. We have not gone to number 4 yet. But that's something that you should plan. A good CAT scan, a good social work eval, because you need to know why this patient lost 2 kidneys. Are we doing the right thing? Is it worth taking the risk? If it's a medical reason and it's been done correctly and the patient satisfies all the criteria with appropriate imaging, planning, it's doable to do another transplant. Simple talk, right? Anybody, any questions? All right, no questions. Thank you.
Wonderful. We got Jane back. I am very happy to see her. So thank you, Dr. Suresh. Excellent talk. I don't know. I think we have people on Zoom. I'm not sure if we're able to see their questions. So almost want to say email them to me. We'll answer them. But thank you very much. So our next speaker is our esteemed pharmacist who's just been dedicated to our program and has truly, yes? There's a question there.
So far, no questions on Zoom. Just updating you.
There's no questions on Zoom?
No questions so far.
Oh, thank you. Perfect.
You're welcome.
Okay, good. Perfect. So James has really developed an expertise in our patient population and in partnering with us to decrease the medication-related bad outcome that can occur after post-transplant. So we're going to talk today about overcoming non-adherence in the underserved population. Thank you so much, Jane.
Thank you for the introduction. Prior to starting, I have no conflicts of interest to disclose. So at the end of this presentation, hopefully we will all be able to define non-adherence and explain the risks in our transplant candidates, understand pre-transplant pharmacologic evaluation process, identify certain barriers to adherence in our underserved populations, discuss medication adherence strategies, and we will go over common immunosuppressive medications post-transplant and associated adverse effects. So prior to transplant, evaluation of adherence in the pre-transplant candidate is very important. And usually in many centers, it's recognized as a relative or absolute contraindication to transplant. Psychosocial evaluation is usually performed by our social workers, and this is an essential part of the pre-workup process. Pharmacist evaluation is also performed in our patient population as well, and if any non-adherence is identified, we usually try to partner with the patient and we try to enforce a minimum of a 6-month demonstration of adherence to therapy. Now, non-adherence doesn't always factor into medication non-adherence. There's also non-adherence when it comes to making appointments, making their dialysis sessions, or even adhering to nutrition guidance that has been previously provided by the providers. Some issues with non-adherence or the patient populations that are at highest risk of non-adherence are those of low-income patients as well as minorities. We will talk a little bit about the consequences in later slides. However, it's important to recognize that the patient population that we're working with does have a high incidence or prevalence of non-adherence. In terms of definition, the World Health Organization, or WHO, defines adherence as the degree to which a person's behavior corresponds with the agreed recommendations from a healthcare provider. Now, these agreements to recommendations usually comes in a shared decision-making process and innovative strategies that focus on patient-centered goal setting for up-titration to guideline-directed medication doses designed to achieve optimal therapy benefits. And beyond medications, like I mentioned earlier, these also include clinic visits, exercise, diet, and blood tests. And the word adherence usually indicates a more collaborative partnership between the clinician and the patient. We often also hear of the word compliance, and this is often used interchangeably. However, compliance indicates a more passive role where patients is just following instructions given by the clinician. What are some consequences of non-adherence in transplant? So research has shown that up to 1/3 of our kidney transplant recipients may be non-adherent to immunosuppressive medications. Studies report that every 5 years after transplant, cases of non-adherence increase by 20%, and that's quite a bit. This non-adherence is responsible for up to 20% of antibody-mediated rejection. It's related to 16% of early graft loss, and there is also a significant economic impact where there is an estimated of $15 to $100 million annually that needs to be dealt with in the healthcare system due to non-adherence, specifically in the transplant population. In terms of measuring non-adherence, how do we measure non-adherence in terms of quantitative assessments? So there's taking adherence versus timing adherence. So as a provider, when we measure non-adherence, taking adherence means measuring the percentage of medication intake that is done by the patient. So for example, if a patient's supposed to be taking medications twice a day, 7 days a week, but they're only taking it, for 5 days a week, we take a percentage of the medication intake based on how many times they're supposed to be taking their medications. whereas timing adherence relates more to percentage of correct interdose intervals. So for example, if they're supposed to be taking medications twice a day, 12 hours apart, but they're missing the 12 hours mark, and they're prolonging their medication intake to 15 hours or 16 hours, this relates to timing adherence. Both taking adherence and timing adherence is very important in our transplant population because there are some medications that we do take levels on. And so if the patients aren't taking it in the correct time, the levels may be skewed. So both of these need to be taken into consideration with our population. Some factors contributing to non-adherence include medication costs. So this is pretty prevalent in our population. And we'll talk about some ways to overcome these non-adherence factors, but busy schedules that make it hard to remember to take medications consistently is another factor contributing to non-adherence. Scheduling appointments or lack of ease of scheduling appointments can lead to non-adherence. The time needed to schedule and attend appointments, especially for working adults, that may contribute to non-adherence due to difficulty in making these appointments. Ease and comfort level of communicating with the pharmacist or other providers, understanding when and how often to take medications, ability to sync medication and receive automated 30 days or 90 days refills so that the patients aren't running to the pharmacy every other day to get their medications. Health condition severity and beliefs about their condition, so how well they are educated about their health condition and what they truly believe about taking medications on time for their conditions. And expectations around possible side effects of the medication is also a contributing factor. So while many contributing factors that we just reviewed do occur at a patient level, however, there's also prescriber level and health system level of contributing factors as well. And we'll go over how to deal with these contributing factors. So in terms of interventions related to pill burden, so as providers, if we're recognizing that a patient is potentially having issues with adherence due to the number of pills they are taking, there are certain things that we can do, and these include decreasing medication frequency to daily dosing if possible. So using extended release formulations, for example, to help decrease that pill burden, discontinuing unnecessary medications, and then requesting blister packaging. So blister packaging is basically when the pharmacy is able to pre-pack the patient's medications for them so that all they need to do is open up the blisters and take all their medications at once. So this is something that we can do to decrease pill burden as well. In terms of interventions related to cost, some things that may be helpful is for medications that may be expensive and we're not sure if it's covered fully by the patient's insurance, we can try to obtain pharmacy costs before prescribing the medications or sending the patients out to go pick up the medication. Work with local low-cost pharmacy programs. So there are pharmacy programs in New York City that work with the low-income population, and also making discount cards and patient assistance programs available. Now, this one's quite important, interventions related to health literacy, especially in our population who may have a lower health literacy or understanding about their health conditions overall. So involving family and other caregivers in medication education is one of the interventions. Referrals to community social work or community resources to help get the patients involved in support groups, for example. Making referrals to home health for medication adherence education. So if the patients have a home health aide, getting them involved. Provide written medication lists with a scheduled grid. So we do this for our transplant patients. We provide a medication chart for them before they leave the hospital. And I think this is a lot more helpful than giving them a whole list of medications. And providing medication education appropriate to the patient's health literacy. So this basically means kind of speaking in layman's terms and meeting the patient where they are in terms of their understanding about their health condition and about the medications, and simplifying a lot of the terms or even simplifying the schedules to meet them where they are. Interventions related to follow-up care, so scheduling in-person follow-up within 7 days of discharge. We also do this as well here. Scheduling pharmacy home medication delivery. This is something that we're still working on. However, our pharmacy is starting to deliver medications to the patient's homes. Sharing care summaries with other care providers, as well as scheduling a phone appointment follow-up within 1 to 3 days of discharge to check in on them, seeing if they have any follow-up questions or last-minute questions now that they've been home for a few days and having to deal with their medications on their own. So with that, I do want to touch upon common immunosuppression medications post-transplant. This will be a brief overview summary. And of course, as with any medications, there are benefits versus risks of immunosuppression agents. So benefits, of course, are to prevent rejection, improve graft function, and increase quality of life, as are with the goals of transplant overall. However, there are risks involved, especially as these immunosuppressive agents are quite potent. There's often malignancy, infection is a great concern, as well as toxicities or adverse side effects that needs to be managed. What are the goals of therapy in immunosuppression? So we want to prevent acute and chronic rejection. There are different stages at which rejection can occur throughout the post-transplant patient's post-op course. So hyperacute, acute, or chronic. Hyperacute can happen within minutes to hours post-transplant, caused by preformed antibodies against the donor. This is now rarely seen in current practice due to the induction agents that we currently have for our patients. So it's less of a concern. However, if hyperacute rejection does occur, it does lead to irreversible damage leading to graft loss. In terms of acute rejection, this happens within days to weeks or months, usually involves your cellular or humoral, so T-cell, B-cell immunity. Reversible damage is possible if managed appropriately early on, and definitive diagnosis is confirmed by biopsy. Chronic rejection is a little trickier. This happens months to years after the transplant. There's a lot of multifactorial pathophysiology that occurs, so inflammation, ischemia, and other processes that we may not catch early on. And this usually leads to irreversible damage, so fibrosis and scarring. So the maintenance immunosuppression strategy we usually use is a multi-drug regimen utilizing different mechanisms of actions to prevent this rejection pathway. Usually we start our maintenance immunosuppression strategy immediately post-op, and it's usually for the duration of the life of the graft. So we will pick one of these agents from each of these classes of medication. So one from the calcineurin inhibitor category, one from the anti-proliferative category, and one a corticosteroid. And here at our center, we usually use tacrolimus, mycophenolate, and prednisone. A lot of side effects are manageable, so in terms of the CNIs, usually there can be neurotoxicity, so headaches, the tremors that occur, and usually these can be managed by decreasing the dose and ensuring the patients are at the goal level in which that our center is targeting. For anti-proliferatives, this has been more of an issue with our patients because many of the side effects occur with the GI side effects where the patients aren't able to tolerate them. So GI side effects include nausea, vomiting, diarrhea. And usually this can be managed by, again, decreasing the dose or increasing the frequency in which the patients take these medications. So for example, if they're supposed to be taking 1,000 milligrams twice a day, we can potentially try to go down to 250 4 times a day to help with managing some of the GI side effects. Corticosteroids with the prednisone, as we all know, there's a lot of side effects, so blood glucose increase, the glaucoma, there's also neural side effects as well. We do try to wean a lot of our patients off the corticosteroids as soon as we are able to, if they fall under certain categories. Now, we had talked about infection as one of the risks in taking immunosuppression regimen, and so I do want to touch upon infection complications and management as well. So most common life-threatening complications of the long-term immunosuppression so infections can occur if patient is over immunosuppressed. this contributes also to graft loss and long-term survival. So this is where immunosuppression gets tricky because too much, they get infection, but too little, rejection can occur. So infections can also increase the risk for post-transplant malignancy, and that this is why routine prophylaxis is usually given post-transplant. And the first steps that occur if the patient gets an infection is to reduce or withhold immunosuppression. However, we do need to carefully consider the patient's history. So if a patient is at higher risk of rejection at baseline, we do want to be a little more careful about withdrawing immunosuppression. There are 3 common anti-infection prophylaxis that are usually given, and these are to prevent cytomegalovirus, pneumocystis pneumonia, and thrush. So for cytomegalovirus, the agent of choice is valganciclovir. We usually prescribe this for 3 to 6 months post-transplant. We'll monitor for neutropenia and GI side effects. Pneumocystis pneumonia, common agents we use here is Bactrim or sulfamethoxazole trimethoprim. There are other agents as well if the patient cannot tolerate the sulfa component of the sulfamethoxazole. This is usually given up to 1 year post-transplant. We do want to monitor for hyperkalemia, myelosuppression, and rash. And of course, should not be given in patients with sulfa allergy. And if we want to give alternative agents, we do have to remember that there may be additional testing required. The third common infection is thrush, and here we do use the clotrimazole lozenges. So we dissolve these lozenges 3 times a day after meals, no food or drink for 30 minutes after. We usually start early after transplant and continue for 1 month post-transplant. There have been data showing concerns with clotrimazole as it is an azole antifungal and increasing calcineurin inhibitor levels. However, there's conflicting results from these studies, and generally most studies have found that it does not cause an issue, so we do use that here. And after giving high-dose steroids, we will restart thrush prophylaxis. And that concludes my portion of the presentation, and I'm open to questions. Okay, so the question is, are there ways to determine how the immune system is working, specifically related to the immunosuppressive agents? So we do tacrolimus monitoring, for example, to help determine if the levels are at goal. Is that what you're asking? So we do look at absolute lymphocyte count, for example, as a way to determine immune system function, especially after thymoglobulin administration. So that's one way to see whether the patient's responding appropriately. Yeah, that's one of the major ways that I can think of right now in determining immunosatisfaction.
It used to be a test that was called Immuno, like it was based on like ATP activity science, and it never worked.
Yeah.
Way to know.
Yeah.
And like and Silex, like so it's tons of very expensive tests for us to show the world that it didn't work.
Yeah.
There's nothing.
Well, the data has just been really spotty on some of these alternative methods of determining immune system function. Yeah.
There was another question.
Yes.
Is there a point where life years can be managed by
Is there a point? So the question is there a point in which non-adherence can be managed by IV immunosuppression therapy? I think one of the ways that I can think of in terms of like switching therapy is, for example, with tacrolimus, if the patient qualifies, we can switch to belatacept. So belatacept is, if you're doing conversion therapy, patient generally starts coming in once a month. It's every 2 weeks for the first 5 doses, then once a month thereafter, and it has to be done in the clinic, so we are able to then, kind of manage the patients a little more closely in terms of ensuring that they're getting the therapy that they need. But the caveat to that is if they're already non-adherent and they're not showing up to appointments, and now that they're also not showing up to the belatacept infusions, which is once a month, then that also poses a problem as well. Other than that, I can't think of alternative IV infusion therapies for the other immunosuppressive agents. We can do things to help the patient if they're having trouble swallowing. We can switch formulations, like switching to liquid, for example, or switching to sublingual, for example. But the only IV infusion that I can think of is the tacrolimus portion. Okay, great questions. Thank you, everybody.
Okay, our next speaker is Dr. Daniel Friedman. He's an assistant professor of medicine here in psychiatry, and he will be speaking on the team approach as it relates to psychiatric conditions before transplantation. Dr. Friedman?
Okay, thanks so much. So I'm Dr. Dan Friedman. I was trained in both internal medicine and psychiatry, so I did a med psych residency. And just I'm going to talk a little bit about the team approach and having a psychiatrist as part of the transplant team and what the benefits that you can get from that. So hopefully I'm your friendly neighborhood psychiatrist and not a threatening one. Mental health professionals as well as psychiatrists can typically help in evaluating and treating all your transplant patients. Some programs require every single patient to be evaluated by psychiatry. Some really just pick out specific patients that they feel they have that they might have issues with in terms of whether they can partner with the team or follow directions or might have problems afterwards. It's important to do this not only for the transplant recipients, but also living donors as well in some cases. When I was at UVA, I had a case where there was an 18-year-old girl who wanted to give her kidney to her minister that she had just met. And in the end, I didn't allow it. But you can get into all kinds of kind of interesting situations where sometimes it's appropriate and sometimes it's not appropriate. And why is a psychiatric liaison important? There's obviously a lot of organs that are needed, and unfortunately we don't have as many organs as we can give to patients. And so in a lot of ways, the need greatly exceeds the supply. And each year, many candidates do die on the wait list. And basically, in order to optimize the outcomes, we try to have the appropriate patient chosen. But, in addition to that, we do want to be egalitarian. We do want to make sure that everyone has the option of being able to get a kidney if that's, possible. Having a liaison has a better preoperative management, better surgical innovations are available right now. We have less toxic immunosuppressant medications that reduce morbidity and mortality, but there's lots of behavioral factors that can really come into play when you have somebody who has to follow difficult treatment regimens and come to appointments and take all their medications, et cetera. In addition, there's kind of a lifelong change that people have to make that they don't necessarily make. A lot of times, especially for end-stage renal disease, a lot of times it's pretty silent. So people don't really know that they're developing significant renal disease, and so they don't think it's real. And they don't understand that they need to make a significant change. A lot of times when I'm evaluating people, I'll really make a point about finding out what their dietary, how they're following the dietary guidelines, what they understand about the diet, and how they're really living their lives day to day, and that'll give me an idea about what's going on with them. Typically, we assist in evaluating and preparing the patient and the living donor and addressing kind of the psychiatric issues beforehand, as well as anticipating what will happen during transplant as well as after. For mood and psychotic disorders, you have a careful selection of patients that will really kind of benefit overall the people that are coming in as well as the whole outcomes. And as I said before, equity is pretty important for disadvantaged patients. Each transplant program decides what their psychosocial criteria are and the relevance of these criteria, but the input from mental health is important. Typically, you'll have a psychologist that's affiliated with any kind of transplant team that's embedded, and in our case, I think we have social workers that do much of the psychological work that will screen people, but then we do need to have somebody to kind of look through. So just doing a GAD7 or PHQ-9 or something like that is not going to be enough. Nothing really replaces kind of a face-to-face interaction. There's always been concerns about whether somebody with serious mental illness or these severe mental illness such as schizophrenia or other kind of psychotic disorders that would be like major depression with psychotic features or something like that, PTSD, MDD, or major depression and bipolar disorder, whether we can transplant these people or not, and whether they make appropriate candidates. You know, I think my feeling and many, health professionals' feeling is that we can treat these people, and they are entitled to have transplants as long as they're carefully evaluated to make sure that they can, follow guidelines. Some guidelines consider a pre-existing psychotic disorder as a contraindication to transplant, even though there's been plenty of studies showing that there have been positive outcomes. So these are the critical issues that typically happen in these cases for the liaison. We help with patient selection and informed consent so that patients can understand what they are signing up for. Recognition and pre-transplant treatments of psychiatric disorders. So sometimes we'll get a patient that is evaluated and requires a year's worth of treatment to get them to the point where they are actually capable of following whatever procedural things that they will need to do in order to get their transplant, so they get to the point where they're capable of having the transplant. We evaluate for substance use disorders. I would say that certainly for renal transplant, you need to do that. Obviously, for other transplants, it's even more important. Compliance with medical regimen. If I have a patient who can't tell me the names of their medications or the dosages or what they're for, that makes me feel a little bit suspicious compared to somebody who can rattle off all their medications and know what they're taking those medications for. Post-transplant psychosis is another one that's pretty important in terms of evaluating the possibility that that will happen, or once it does happen, what to do for that, and as well as what medications to avoid. And then evaluating kind of the immunosuppressive drugs and the drug-drug interactions that were caused by that and the problems that come from that. Knowing what a transplantation patient's adaptive strengths and deficiencies are beforehand is really important, and it strengthens overall the working relationship between us, their family, the patient, other caregivers, and it improves the support that the patient will get. Also, patients who are waiting a long time, I'll have patients who I think I have one that I've been seeing for almost 3 years now that looks like they're finally listed, and hopefully they'll be able to get a kidney at some point in the near future. But sometimes the wait list is very long, and we're also there to help a patient adapt to the fact that they haven't been able to get a kidney yet, or there is a long wait. Early diagnosis and management of other psychiatric conditions is really essential overall. Choosing a candidate should be overall egalitarian, but otherwise, criteria for listing patients vary in response to total mental health considerations. Selections varies. It used to be that people didn't want to transplant somebody who's on a methadone, in the methadone program, but in truth, if you're in a methadone program or you already have identified the fact that somebody has a substance use issue, that's a known quantity, whereas if you have no idea whether they have a substance use issue, they're using substances and yet they're doing it secretly, that's something that you don't know about and you don't have an idea and you can't help with. So truthfully, knowing there's an issue really actually helps out and helps you to be able to manage that patient more effectively. There's been several studies showing that people on chronic maintenance methadone therapy and treatment actually have a favorable outcome. But typically we can restrict and not be so equal in terms of the patients that we decide to have to allow for transplant in regards to their advanced age. We might be ageist, people with memory deficit problems, people with a history of alcohol or substance use, as well as people's size. Sometimes people will not let people be transplanted because they're too large. But we can adapt and we can adjust for many patients. Patients suffering from psychotic disorders were also, as I said before, prejudiced against. But there have been plenty of studies showing that those with psychotic disorders actually have a favorable outcome. But it requires a lot of support from their family, a lot of support from the treatment providers and the mental health team. So the psychiatrist as a team member helps to choose who's a good candidate. At times, the evaluation that the psychiatrist does can be many, many months later than when the initial evaluation from the team happens. So, for example, we just had a patient who she had an elevated GAD-7, the General Anxiety Disorder 7, test, as well as the PHQ-9. They were both elevated, and she was feeling, they felt this needs to be seen by me to make sure that she's okay. And when I saw her, she was fine. Her GAD was, I think, 3. Her PHQ-9 was like 2. And when we were discussing it in team, we were talking about why were the numbers so different? Why were they so different when she was evaluated? And the reason was because she was just diagnosed at that time. So she didn't know what was going on. She didn't know what the plan was for the future. She didn't know if she could get a kidney or not, or what would happen. She hadn't even started hemodialysis yet. And so she's like thinking, oh my God, I don't know what's going to happen to me. And meanwhile, by the time I saw her, many of those questions had already been answered, and she felt much better. She felt much more confident about what would happen, and thereby we didn't really have to treat her for any pre-existing conditions or possible conditions like that, and we just made it so that I would follow up with her when she needed to. She actually agreed to have kind of a follow-up in several months, and those are the kinds of things that we can add to a situation. For any transplant recipient, it's important to figure out whether a patient can adhere to a complex regimen. Most patients are able to manage their own medical care eventually after transplant, but there's really no way for somebody to be able to follow all their treatment advice right when they've had their transplant. They're quite ill, they need a lot of extra support, and so sometimes we get patients who really can't identify any social support at all that they're going to have. They can't identify a family member that will be consistent, or community members that will be helpful, and those present difficulties because you really do need a lot of social support. There's just so much that we can provide for patients, and they really do need to have somebody else kind of helping them. The incidence of noncompliance varies from study to study, but it basically, noncompliance accounts for about a 7-fold increase in renal transplant failure. So it's very important to figure out medical compliance. We've certainly had patients who've only taken, 1 month's worth of their medicine after their transplant because they just said, oh, they only gave me a bottle with 30 pills in it, so I don't need any more. But obviously they did, and so hopefully we help to kind of weed those kinds of patients out, or at least educate them to the point where they actually take their medications. Common factors leading to noncompliance can include depression, substance use that's active, memory impairment, adolescence, and social or financial instability, all kind of for pretty obvious reasons. Patient attitudes towards efficacy and how they can make a large impact, how the care can make a large impact is pretty important. When medical problems, like I said before, are asymptomatic, it's really hard for patients to say, oh, I'm sick and I need to follow these instructions, so they tend to ignore those instructions. When people are depressed, they tend to have a negative view, or a negative view of the outcome or the future, and that will lead them to not follow certain things or have a negative way of responding to their problem at the time. Obviously, substance use is going to, that speaks for itself in terms of people's inability to follow up if they have their lost weekend or something like that. But dietary problems among people with diabetes, as well as people who are overweight or obese, people with smoking habits or physical inactivity, all will affect the outcome, and even those kinds of social support in terms of lifestyle is very important and needs to be repeatedly addressed for many of our patients. A transplant recipient's expectations and attitudes have a marked effect. So if people think, oh, well, my brother-in-law had this, so I know it'll be fine. He had a pretty easy time. It's problematic when they've gotten some either disinformation, misinformation, or problems with understanding exactly what the procedure is. Like, they're not going to get a kidney and it's magic and they don't have to do anything. They have a lifelong change in their lifestyle, and they have to be adjusted to that. Depression and anxiety leads to a lot of negative self-perceptions. They can cause them to make poorer choices. Patients who have these negative thinking can really be hooked up with a psychologist or a LCSW who does good CBT therapy, and CBT therapy has been quite effective in helping people dealing with a lot of their conditioned negative thinking. The team together tends to make a kind of a realistic approach to who's going to have a good outcome for patients. But teaching patients at their educational level is very important. A lot of patients will not understand some things that are quite complex, so keeping it very easy, making sure you're using a language that is appropriate for the patient. I've certainly had patients who insist on talking in English, and they say that they know English and they'd rather be addressed in English, and yet I will find in my interactions that there's many times when they seem to misunderstand a key component of what we're talking about, and although it seems like they're understanding, they actually aren't. And although you don't want to upset somebody, there has to be a way that we can address a patient and say, you know, I think it might be advantageous for at least some of our sessions to be in your language of origin. Because it's going to be helpful, and when it gets right down to it, if it's between a failure of their transplant or offending them because you want to speak in a different language, I would choose the latter. Expectations can be harmful. A lot of times professionals who are not as familiar with transplants, so medical doctors that don't know as much about transplantation, or people getting information from Reddit or something, I usually restrict my patients. They can only go to websites that say .gov or .edu. They can't go to any other websites. But people get a lot of misinformation, and they have a lot of reasons why they think that that either they're a shoo-in for a transplant, it'll be easy, or that it would be too hard and they better not get it. And so it's also up to us to educate people and to let them know, what hopefully they can be capable of. So for depression, it can have a significant impact on a patient's cognition. It could include their ability to concentrate, their memory, their behavior, their affect. And the thing is that, people who have had a history of depression in the past, they are certainly likely or possible to have another reactive depression or another depressive episode, depending on what's going on in their lives, especially with the medications that we do need to use and some of the treatments that we have, or the condition that they're in, or the pain that they might have, all can lead people to another episode. So being prepared for that, being prepared for the changes in cognition and vegetative functioning are all important. Overall, depression increases the risk of mortality as well as disability from major diseases, including end-stage renal disease. Factors increasing morbidity related to depression include excessive weight gain or loss, altered immune function, and overall there's the theories in the same way for many other disease states. For depression, it's an elevated cytokine response. There's increased interleukin-6, increased interleukin-2, increased interferon gamma. There's many cytokines that are elevated, and the reasons why people are more depressed with diabetes or more depressed with hepatitis C or more depressed with many other disease states is because it mimics the same thing that happens in depression. So all of those things are happening. So that can certainly make an impact. Loss of activity, not exercising, and changes in the way they process information all have a significant impact that will impact the team, really, and the transplant plan. Depressed people typically have decreased perception of their own self-worth, as well as feelings of lethargy, fatigue, and it will make rehabilitation much more difficult if it's not treated. So people who are on the precipice, I try to get them to, sometimes people will prophylactically go on medications if I feel like that's important, if I feel that that's close for them. There's many people who have had a history and they feel fine, they look fine, they've got a lot of support, and they don't need to prophylactically go on something. But other patients, if I feel like, increased stress for this patient may lead in this direction, I may actually pre-treat them in the hope that I could avoid a depressive episode if we're already treating. For depression, medical morbidity exacerbates depressive symptoms. So the more pain you have, the more problems you have, the more depression you have. The more depression you have, that then will then lead to higher feelings of pain, et cetera, et cetera. And it's just very cyclic. With treatment, usually you can kind of break the cycle. It does not, depression doesn't include people from transplantation like many of the other conditions also don't, but it emphasizes the importance of having that diagnosed. Treatment of depression pharmacologically and psychologically is important, so you could certainly start someone on SSRI is a very good outcome, and it's quite easy usually to do those. You need to make sure that people understand the psychopharmacology. I know we just had a patient last week where we were thinking about starting duloxetine, and duloxetine can be quite toxic if your creatinine clearance is less than 30, which it turned out to be, so we couldn't use it. So it's mostly renally excreted, so we couldn't use that medication, even though we were hoping to use something that would help modulate pain for the patient. And the spinal thalamic tract is modulated by serotonin and norepinephrine, so a lot of SNRIs are helpful for pain, like duloxetine, but we couldn't use it in this case. CMV infection is also, and rejection are kind of a leading cause and something that can be quite difficult, causing an acute onset of post-transplant depression. Bipolar disorder, a more serious mental illness, does not preclude somebody from getting a transplant. Mood stabilizers, though, can be somewhat tricky to work with. Lithium, of course, is quite a difficult medication to have a patient on who's on who has end-stage renal disease, and yet we have patients I've had floridly manic patients that will only respond to lithium in teeny tiny doses. I can give them anything else and they're quite psychotic and manic, and then I give them a tiny dose of lithium, and within 2 or 3 days they're under much better control. Those are quite, those patients are very difficult. They might not be able to get a kidney because of those reasons. But mood stabilizers in general can be toxic. The anticonvulsants have a potential effect to interact with the immunosuppressive medications. Some anticonvulsants most of them will affect blood lines, so certainly carbamazepine and divalproex will. Second generation antipsychotics cause metabolic side effects and diabetes, and also require you to be a little bit more careful, although in terms of treatment, you can use those medications quite easily in a patient who has renal insufficiency. At times, smaller doses of medications, or sometimes small doses and multiple medications, but I'll keep them all small, sometimes works quite well for people. Post-op bipolar exacerbations can occur. Typically, prednisone is the thing that's the most problematic, causing mania and psychosis. Identifying those patients and making sure you use a prednisone-sparing regimen would be quite important. For psychotic disorders, as long as there's been a psychotic disorder and it's well maintained with a lot of community support, a lot of social support, family members, they can be successfully transplanted. And there's been studies showing that people have had successful transplants even though they've had a serious mental illness like schizophrenia or schizoaffective disorder. For substance use disorder, prognosis is favorable with good patient selection, so you have to select the patient appropriately. And patients, so they need to freely acknowledge their diagnosis and agree to sobriety. Patients may need to see an addictionologist, a specialist. Naltrexone and other medications can be used. Patients with a narcotic addiction can successfully be transplanted on methadone with a methadone maintenance patient. It's just that their pain management is going to be a lot more difficult to manage because of their history, but that's not something that the pain service or someone can't manage for the team. Besides the many medical complications patients experience, you need to manage the medication side effects, episodes of rejection, episodes of infection, and the continued burden that people will have because of economic stress, because they can't work. A lot of times, even though patient support networks will say, oh, we'll be there every day, we'll be there to do anything, many times we'll see patients' family members or support systems, evaporate after the transplant, unfortunately. So again, looking out and seeing the family, I have to say, I don't think we do that as much as we probably should. Maybe have a meeting with the family members, or I don't. finding out, how supportive they truly are. For new onset psychosis that can happen post-operatively, it can occur likely as a result from the stress. Related exacerbation of a psychotic disorder can be due either to abrupt discontinuation of medications that happens because of surgery or because of drug-drug interactions or from a medical complication. Deliriums can occur due to intraoperative complications, toxicity from medications like CNIs. We did think we had a patient who had a catatonia directly related to tacrolimus, so we did. So I'm getting positive things that we did. So okay, we did. And so having an understanding of what some of these medications can do and their side effects and psychiatric complications from them. And believe me, every medication, every antihypertensive has a psychiatric side effect. Even hydrochlorothiazide has been known to cause psychosis. So, you'd be surprised at the side effects from medications, from ACE inhibitors. So, again, we're using complicated medications post-op transplant, and there's many, many side effects and many drug interactions that a psychiatrist, typically because we do a lot of more pharmacological training, we have an expertise in. So there's other problems, can be infections that cause deliriums, drug or alcohol withdrawals, metabolic changes, vitamin deficiencies, and endocrinopathies and hematological problems. Also, just discuss quickly that CNIs have neurological side effects: tremor, headache, restlessness, insomnia, vivid dreams, photophobia. In severe cases, there can be cognitive impairment, coma, seizures, etc. Factors associated with neurotoxicity are believed to include hypercholesterolemia, hypermag, and genetic polymorphism. And we talked to you about the CNI-induced catatonia, which we did switch them to a different agent with some success, I would say. Yeah, exactly, and a lot of Ativan. But anticonvulsants, like we said about valproic acid, carbamazepine, oxcarbazepine, they have P450 inducing properties that may decrease the bioavailability of a CNI, so you have to take that into account. And then I just wanted to end with an example of a patient, which we were just discussing last week. We have a native Spanish speaker, really unable to speak English. He's a 54-year-old man, first seen in 2022, past medical history of diabetes and hypertension, and in the Dominican Republic had recurrent renal calculi of an unknown type, and caused, in the end, end-stage renal disease and hemodialysis, GERD, diabetic retinopathy, cataracts, etc. No psychiatric history before any of this. And when I was asked to see him, I think he had been placed on a very small dose of fluoxetine, 10 milligrams, by his primary care doctor because he seemed depressed, but that was really the only interaction that he'd gotten. Just so you know, 80% of all psychiatric medications are prescribed by non-psychiatrists. Only 20% of psychiatric medications of any type are prescribed by a psychiatrist. So the patient was when I met him, he was very, very upset because he didn't get the appropriate treatment when he was in the Dominican Republic. And for him, his renal calculi came from something he could have avoided in his diet. And if he was just told, he would have not developed, repeated renal calculi ending in renal failure. And so he was really upset that he had to start dialysis, really upset that this could have been prevented. And when he came to the U.S., and he got appropriate treatment, he did well, but he was still quite angry, very angry, as well as depressed. He told me that he was depressed since 2017. He had to stop working then. He had, more sadness, anxiety, kind of anhedonia, poor sleep, crying spells, lost about 20 pounds. And since then, he'd had kind of chronic passive suicidal ideation, so nothing active, but repeated thoughts. He tended to isolate, wasn't doing a lot, wasn't as active as he'd been. And like I said, he'd been on 10 of fluoxetine, and his PCP gave him mirtazapine at 50. For mirtazapine, the lower the dose is actually the more somniferous it is. So 7.5 is actually more sleepy making than 15. And he felt the meds weren't working. I don't love fluoxetine as a medicine because the half-life is super long, and then norfluoxetine, which is a metabolite, that has a week-long half-life. So sometimes it's difficult to work with that medicine because it takes 2 months or 3 months to really figure out what one dose did to, accurately. So I usually prefer shorter-acting SSRIs, but he was already on it, so it's easier to just adjust something that he's already on. I went ahead and I continued asking him questions about his depression, but also because I'm a psychiatrist, I ask him, questions about mania, OCD, all kinds of things. And when I asked about hallucinations, he said, oh yeah, I have had voices, when I got really down. And this was the first time anyone had heard that he'd ever had any auditory hallucinations. And he had voices that told them he said that they were pushing him. The voices told him to harm himself. He stated that when I had seen him, he had last heard a voice about 2 weeks before that, but they weren't familiar, but they were repeated, the same voice all the time. And he noted that when he felt more depressed, he heard more voices. So it seemed more like a major depression with psychotic features. He was not really afraid of the voices, kind of ignored them, but was significantly bothered by them. He had a lot of faith in God. He felt that was protective, and he could ignore the voices. And even though the voices at times told him to throw himself in front of a car or something like that, he would ignore them. And he agreed at the time to take more medications in the hopes that we could decrease his auditory hallucinations. We went ahead and started him on Risperdal 1 milligram QHS. I might have started at half a milligram, but we went up to 1 milligram. We also increased his fluoxetine from 10 to 20, and after that, he did so much better. So he had a problem with being sad, crying spells, etc. And now he's not having any crying spells. He's sleeping better. He had a difficulty with flipping his sleep-wake cycle and sleeping during the day, which we fixed with a little bit of quetiapine. But overall, he's remained on these. He hasn't had voices in, I would say, probably about a year and a half. Much, much happier. And I just think about the amount of time this poor person suffered, from these auditory hallucinations that no one just had the wherewithal to ask about because, they feel uncomfortable asking about voices, or they're not sure that they know how to ask them in the right way. But in this case, it was pretty important. At the time, he felt very worthless. I feel I'm worth nothing, is what he said. And with treatment, he got remarkably better, and I know that he was just listed. Thanks. Any questions?
I have a question.
You in the back row. I may not be able to answer it, but you could ask it.
So I liked how you touched upon a lot about depression, which I think is underdiagnosed in our population here. However, there's a lot of stigma, I think, in our population regarding talks about mental health and seeing a mental health professional. What are ways in which you think there's workarounds around that? What would you tell patients, or how to help patients in taking that step?
Yeah, that's interesting. Obviously you can strong-arm things in one way because you could say, without getting this psychiatric consult, you're not going to get an organ. And so you could kind of make it happen, which I think I see sometimes. But, including them, including their family members, in all these kind of conversations, sometimes actually having a patient separate from their family and talking to them just regular. I'm a big believer in having conversations, very plainly without a lot of jargon, a lot of, medical talk, can be pretty helpful. I often will talk to people about that they don't have to be on medications forever, that just because they're going on a medication to treat something that's going on now does not mean it's permanent or for the rest of their life, and that I'm available for them even when they're off the medication. So we would try medications for a certain amount of time and then see how they do off those medications, but I'll be available to see whether I can help or whether there's problems to maybe have to restart. But I know that there's a lot of stigma, and I think they know that there's a lot of stigma as well. So it's not something that's unheard of for them. They have TVs, they watch movies, they see what happens in the general, public. But yes, there are certain communities where there really is a big stigma. But I think addressing it straightforward and being very honest and also expressing your own concern so that they can see, my provider has feelings and they have emotions and they are concerned about me. I think that will go a long way, and people pick up on that.
Yeah, thank you for that. Working around those stigmas is certainly a big challenge in our pre-transplant workup. I have another question for you. As you mentioned, transplant psychiatry is becoming a transplant specialty. There's some programs who have everybody seen by psychiatry, and that's because the incidence of mental health issues and psychiatric disorders and organ damage is very high. Now, in liver transplant, it's almost something that we accept, right? Because there's a big part of how people have damaged their liver that was related to psychiatric illnesses.
Mostly.
But in kidney disease, it's harder to explain. So why do you think the incidence of psychiatric needs is so high in the end organ damaged patients? And how can we better support the population to increase their access to care? Because I believe that some of the psychiatric illness also leads to decreased access to care.
Yeah, I have to say, I just think more education for them, having them see more mental health professionals that don't have to only be psychiatrists. There could be psychologists, there could be LCSWs, all who have good training. And, I'm a big believer in groups. And so having more groups, having more, even if they're drop-in groups, so that people don't feel like they have to go every single time. But, maybe making it in a convenient place, maybe making it near where they come for their follow-ups anyway. But having groups of people in similar situations who can all hear kind of the same information, I think that can only be helpful because they not only see what's going on with them, they hear stories from other people as well that they can self-identify with, and thereby maybe kind of scooting around an issue and being able to help people out. So having those options, getting people to do it, that would be just taking encouragement. I've worked with patients in my primary care practice when I had that. I would say you really need to quit smoking, and I would say it for, I'm going to say it for 2 minutes every visit, and then 5 years later they quit smoking or they quit drinking. So you will have an impact as long as you are, consistent with how you address things and the way you address it. If you come across, cross or mean, they're not going to respond to it. But if you come across in a caring way and say, I know it upsets you when I bring up this issue, but, as your care provider, I feel it's really important to do it, so please allow me to do so. And then, as long as you telegraph all your moves, no one's going to be angry. Okie doke. Thanks.